हेलो। हाय लावण्या।
हेलो। हाय
हेलो।
मैम। गुड
हाय।
इवनिंग।
हाय, गुड इवनिंग। हाउ आर यू ब्रज? स्कॉटलैंड में मन नहीं लग रहा है तुम्हारा?
या
हम्म। काम करे ही जा रहे हो स्कॉटलैंड से भी। व्हेन आर यू कमिंग बैक?
यस मैम। आपके 12th मैम। 12th 11th आई एम लिविंग फ्रॉम हियर।
आई एम सो हैप्पी दैट यू आर स्टिल so much dedicated to our MP ISAR and our webinars. एंड कितना अच्छे सारे लोगों को इकट्ठा कर लिया हमने। सब सब लोग आ भी गए। It's very nice. Three state. People started two state. We are starting three state. Hi, Seema. I think Seema is just joining, right? I think they have to rename. Dr. Rajoria, I think your name is coming Seema Prakash. So go on these three dots and change it to your.
I'm joining from my laptop, ma'am. Good evening.
Good evening. How are you, Dr. Rajoria? I keep seeing you doing lots and lots of activity on DGF platform.
Yes, ma'am.
And
Best wishes to you.
I keep meeting your daughter. She's so cute. She met me in Noida. She took my picture, sent it to me on my mobile. She's very, very,
Yeah,
very
ma'am.
cute.
She's a great fan of yours, ma'am. I'll
Thank you.
join from my laptop, ma'am. It's
Okay,
raining in
okay.
Noida. Yeah,
I
it's
know.
raining here.
It's raining everywhere. Hi.
Mhm.
How are you,
Hi.
तारिणी जी? तारिणी, आपका
या
नाम चेंज कर लो.
क्या बात है। हेलो।
Hello, Tarni
हेलो
ma'am.
अर्चना। हेलो अनीता।
Hello, ma'am.
कितने दिन के बाद देखने को मिला
Pleasure,
है।
ma'am. Yes, yes, yes.
अनीता तुम ये बताओ, तुम्हारा एक फोन मेरे पास ना मॉम के नाम से है, तो क्या उसमें अनीता डाल दूं?
वो ना
हैं?
युक्ति ने मॉम करके सेव करा और मैंने कहा तूने तारनी मैम को ऐसे ही भेज दिया और वो
नहीं
आपके
नहीं,
फोन
तुमने
में
एक बार कहा था ना कुछ प्रॉब्लम आ गई थी, फोन हैंग करा क्या, कि वो इस नाम से सेव कर दो। अब वो
हाँ
उसी नाम से सेव है, अब मैं क्या करूं, अभी रिकॉर्ड
मैं
तो नहीं हो
नोट
रही
नंबर
मीटिंग?
भेजूंगी। हाँ
है?
मैं आपको खुद भेजूंगी अपने नंबर ना
अच्छा।
कि
अभी
वो
मैं
सेव कर
अभी
लेगा आपका
रिकॉर्ड तो
आसान
नहीं
हो
हो रहा
जाएगा।
है ना?
हाँ
रिकॉर्ड तो नहीं हो रहा ना?
नहीं 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 नहीं।
ओके
Hi,
ओके।
Deepika.
Hello,
Welcome.
hello. Hi.
Welcome.
Good evening, ma'am. Good evening, ma'am.
अर्चना
Hi,
लुकिंग
Dr.
वेरी
Archana,
प्रिटी।
ma'am.
अर्चना, हेलो दीपिका।
Thank you, ma'am. Thank you so much.
सो लवली क्यूट फेस।
So, where is your team, Dr. Brejpala? All the your MOC and your conveners.
मैम सब धीरे धीरे ज्वाइन कर रहे हैं और एक आधे
हाँ
मिनट में
कौन?
कर जाएंगे।
नहीं, वो ब्रजबाला पता है
देखो
स्कॉटलैंड से
इसमें
बैठ के
काम
अरेंज
अगर
की है।
हम
शी
कर
इज
अरे
इन
देते
वाह।
स्कॉटलैंड.
और
यस.
दूसरे उसको
अरे
भेज
बाप
देते
रे,
हैं।
enjoying in Scotland. Good. You are not audible, Braj.
डॉक्टर ब्रजवाला मैम आप म्यूटेड हैं.
I
यस.
came from Ayrshire to Scotland, now traveling to Scotland
ओके
after
मैम.
Ayrshire and India night, India day.
इंडिया डे. सो मैम हॉलीडे के साथ में काम भी बहुत जरूरी है. तो
Actually, we
ब्रिजवाला तो
started
बहुत
this
बिजी,
month this new
ऑन
series,
कोर्स।
na, that's why.
यस.
कितना ट्रेवल करके आई है और लुकिंग वेरी फ्रेश है ब्रिजवाला। दीपिका हमारी ऑल
Yes,
ओवर
Dr.
एवरग्रीन।
यस मैम. गुड इवनिंग डॉक्टर तारिणी मैम. गुड इवनिंग.
या
Tarini.
गुड इवनिंग
Yeah.
एवरीवन।
डॉक्टर सीमा ने ज्वाइन नहीं किया अभी.
करेंगी, आ जाएंगी. कोमल, हाय डॉक्टर कोमल.
Yes, ma'am. Good morning. Good evening, ma'am.
हाय
She's a
डॉक्टर कोमल.
very new and a good addition to our team, Dr. Komal.
यस.
And
Thank you,
just
ma'am.
done her MRCOG.
ओह अच्छा.
Oh,
Yes, yeah,
congratulations
young girl
कोमल।
just done the
वंडरफुल.
MRCOG. She got added into the MRCOG club.
वेरी
So
नाइस.
yes,
Thank
and
you so much, ma'am.
very enthusiastic girl, and very brilliant.
सो डॉक्टर
Thank
कोमल
you,
विल
ma'am.
कांटेक्ट यू फॉर टिप्स एंड ट्रिक्स. अभी हम प्लान ही करते रह गए. पूरा ग्रुप बना था एमआरसीओजी प्लेटफॉर्म देने के लिए. अभी हम सोचते रह गए. सो वील आस्क डॉक्टर कोमल फॉर टिप्स एंड ट्रिक्स लेटर ऑन ऑफलाइन.
अरे
Definitely, ma'am.
आई
Yes, ma'am.
कैन लॉन्ग बैक, बट मेरे बेटे को फीवर हो गया, बिल्कुल क्रोनिक, जा ही नहीं रहा, सो आई हैड टू कम बैक, जस्ट अपीयर फॉर वन एग्जाम, दैट्स ऑल, वन पेपर आई अपीयर। feeling so regret always, and I cleared that.
मैम इट्स
Good
नेवर
evening,
टू
ma'am.
लेट। मैम फिर से दे दीजिए, फिर से try।
I know, फिर से दीपिका पढ़ाएगी तो दे देंगे,
मैम
दीपिका
फिर
पढ़ा
साथ में
देगी
पढ़ते हैं, हाँ बिल्कुल।
Yes, ma'am.
साथ में
Ma'am, I
करके।
had a study partner from Malaysia and Dubai, and they were over 55 years, and they were my
I
study
हम भी
partner.
उसी वाले रेंज में है, तो अब डॉक्टर कोमल हमारी टीचर बनेंगी और हमें गाइड करेंगी।
मैं क्या
डॉक्टर
बोल रही हूँ,
तारिणी और मैं करेंगे।
आजकल मिड लाइफ में बहुत सारी एक्टिविटीज कर रहे हैं डॉक्टर्स, नहीं एक्सरसाइज कर रहे हैं, योगा कर रहे हैं।
यस
मिड
मैम,
लाइफ तो आई थिंक एक मिड लाइफ एमआरसीओजी क्लब बना लीजिए,
आजा आजा
और
यस
तो
मैम,
कोमल को उसका वो बना दीजिए
हेड
ट्रेनर
बना देते हैं,
डॉक्टर।
हाँ।
और
हाँ
और सबका जितने भी लोगों को अपीयर होना है, दे ऑल कैन बी। सो कोमल, यू गॉट अ न्यू अपॉर्चुनिटी हियर।
हाँ,
Yes, ma'am.
आपको
Definitely, ma'am.
बहुत सारे स्टूडेंट्स मिल गए, वो सारे
मिल
तैयार
गए।
हैं।
चलिए
Yes, ma'am.
यस,
डॉक्टर रुद्री,
कैन वी
आज तो
स्टार्ट?
हमने ही स्टार्ट करनी है, तो बोल दीजिए सुदीप जी को। और
So we will start.
लावण्या, सीमा, अनुराधा, आई डोंट नो, आए नहीं है अभी
I
तक।
मैम वो
think
लिंक का
Lavanya is
कुछ लिंक का
visible
प्रॉब्लम
here.
हो रहा था।
Seema.
हु हैज गॉट द लिंक? क्योंकि मेरे पास तो मेल आई, मैंने मेल से ज्वाइन किया है, ईमेल से।
सभी के पास मेल ही, हम लोग ने
Ma'am,
सुदीप जी का
जिनके
काम
mail
बहुत
ID आए
परफेक्ट है,
थे,
वो
हाँ
पर्सनल ईमेल ही भेजते हैं सबको।
हाँ, तो फिर हो सकता है उनको मेल नहीं मिला, क्योंकि ग्रुप के ऊपर आ रहा है कि प्लीज सेंड लिंक।
हमने रजिस्टर कराया ना, इसलिए मेल आ गया हमें।
हाँ
हाँ,
नहीं,
रजिस्टर करना पड़ता है,
ऐसे
रजिस्टर
तो
करो
नहीं
तो
था,
मेल आता
ऐसा नहीं था, बट एनीवे
no, no,
लावण्य,
no.
आई जस्ट हर्ड लावण्य टॉकिंग, शी वाज काउंसलिंग सम पेशेंट अबाउट हिस्ट्रोस्कोपी, आई जस्ट हर्ड, सो शी वाज
मैम,
हियर।
क्योंकि ये आए नहीं ना, ज्वाइन नहीं किया इन्होंने। डॉक्टर
Dr. Seema,
मैं
Dr.
देखती हूँ, आई
Lavanya,
जस्ट चेक ऑन
and
द ग्रुप।
where is Dr.
Gunjan,
Anuradha?
Gunjan is also not there. Gunjan, Sunita, Astha, Smita, Smiti, Mekhla.
Ma'am,
Meghna
I
has
am
joined.
there, Dr. Asha. Ma'am, I
Hi,
am
ma'am.
there.
This is UP.
I'm
Good evening, ma'am.
I'm also
Hi,
here. I
hi,
think Dr.
my
Seema के
dear
नाम से आ रहा है हम
friend.
सबका.
Hi, my dear
Um,
friend, the
I'm
Yukti.
Dr. Smriti ma'am. I think mine is coming in the name of Dr. Seema. I don't
Ma'am,
know
there
why.
is some
So
problem
let
in
me
the
just
link
see.
provided in the
No, I think
WhatsApp group.
No, no,
I also
no.
joined. My name
I
was
think yes.
Seema.
Yeah, I
नेम
think
हम
Dr.
अभी
Asha
All
had
चेंज
to
should
करवा
join
be
from
देते हैं।
our
fine.
personal links.
नेम
हमने
अभी
personal
चेंज
link से
कर
join
देते हैं।
करना
आप
होगा.
ये जो थ्री डॉट
हमने
है ना,
शायद
इस पे जाओ, थ्री
फिर
डॉट
सीमा
पे
सीमा नहीं ज्वाइन कर पाएगी, अगर आप सीमा के लिंक से ज्वाइन करोगे तो सीमा नहीं ज्वाइन
नहीं
कर
नहीं,
पाएगी।
ऐसा नहीं है, ऐसा नहीं है,
नहीं ma'am, I have
ऐसा नहीं
changed
है।
my name.
पीपल कैन ज्वाइन फ्रॉम।
अभी आपका आ गया, आस्था श्रीवास्तव आ गया, तो डॉक्टर सीमा के उससे कैसे? अच्छा, यू हैड पुट सम अदर नेम।
No ma'am,
सीमा
I
शायद
सीमा
joined
ने अपना
from the
भेज दिया
link
ना,
that was shared.
अच्छा,
सीमा ने
अपना भेज
अपना,
दिया। अंडरस्टूड
हाँ,
अंडरस्टूड।
सीमा ने अपने भेज दिए हैं सारों को ना, तो मैंने भी ज्वाइन किया तो सीमा ही नाम आ रहा था ना उसमें।
अच्छा ठीक है, मेरा
So
तो
madam, you know, एक वो Seema believes in uniformity, so she wants everybody to be Seema today.
यस, दैट्स राइट। सब लोग सीमा बन के आ गए।
सब लोग
ठीक
सीमा
है,
बन के आ जाओ।
राइट। तो
How are
अब
you, Yukti? How is Noida?
Yeah, ma'am, it's fine.
It was so pleasant
हाँ,
to see you
कितने
in
सुंदर
Noida.
लग रही है। हाँ, शी इज लुकिंग सो प्रिटी।
मतलब वो यंग लड़कियां हैं, वो एक फेस ना, वो यंग वाला जो उनका चार्म होता है, वो अलग ही होता है।
यस मैम।
Good evening, Tarini, ma'am. Hi.
डॉक्टर सीमा को फोन करूं क्या? मैडम को तो ज्वाइन करना था ना। कैन वी सी हर? इज शी देयर ऑन द ग्रुप?
Yukti, can you please call
Ma'am, I am
Dr.
calling
Seema?
back. Ma'am, I have already dialed. If ma'am will
And Dr.
And
Lavanya and
Dr. Lavanya and Dr.
डॉक्टर
Anuradha also.
join नहीं करा।
यहाँ पे ज्वाइंट तो दिख रही है, बट उनका बंद है वीडियो। और वो यहाँ पे डॉक्टर लावण्या का नाम तो आ रहा है। एंड
Komal, Dr. Anuradha को call कर लो please.
हाँ, डॉक्टर अनुराधा का।
Yes, ma'am. Yes,
Komal,
ma'am.
please call Dr.
Yes, yes, yes,
Anuradha
ma'am.
also.
Ma'am join करना भी, ma'am
I'm
is
doing that,
Seema
ma'am.
has
आ गई।
joined.
डॉक्टर
Seema
सीमा
is
है।
visible.
डॉक्टर नेहा इज कम, सो
Hi,
आई थिंक
ma'am.
डॉक्टर
Good evening,
अनुराधा।
ma'am.
Hi, good evening. Good
Hi,
evening,
ma'am.
Dr.
Good
Archana.
evening.
हाय, गुड इवनिंग
Seema.
मैम। डॉक्टर सीमा, गुड इवनिंग।
Good evening, everyone.
गुड इवनिंग।
हाय,
I just reached home. I was stuck up in a very bad endometriosis case.
अच्छा, ओके
Took me 5 hours today. So I have just reached
ओके।
without lunch, without water, nothing I have taken.
so you're
साथ
got a
में खा रहे
intermittent fasting, Seema. Intermittent fasting हो गया आज आपका।
Actually, आज forceful intermittent fasting, ma'am.
Whatever it is.
That's why
Endometriosis
I
is
got a
something
bit
which you
late.
can.
Sorry for that.
Can someone please call Dr. Lavanya Anuradha so we can start?
Ma'am, Anuradha ma'am is
Because
logging in. I will call Lavanya ma'am.
okay,
I think Dr.
and
Lavanya
Dr.
was
Lavanya
So,
also.
joined तो किया हुआ
we
है
have first session people, but we just wanted all the president secretaries of the all three
Actually,
chapters.
3 states. So
So Lavanya, Anuradha, Seema ji is here. Gunjan, I don't know Gunjan. I can't see
yes,
Gunjan.
Gunjan.
So just I think in 5 minutes, then we can start. Yeah.
we have to start in time. Woman once called now.
Hi Lavanya.
Yeah, hi. Hello.
Yeah, Dr.
Yeah,
Lavanya has joined.
hysteroscopy. Your
So we shall
hysteroscopy
we start,
counseling is
Lavanya?
done or not?
All done.
I could hear you joined in earlier, and I think you were in
Oh,
consulting.
yes.
I think this
I
consult.
was trying to put my laptop up. I think this, your Komal is also calling. I just tell her.
Dr. Lavanya, will you call Dr. Anuradha also?
Okay, ma'am, Lavanya ma'am is here.
So I think it's 5 o'clock now in India.
It's 5:09. Yeah,
So shall we start?
ready.
Because I am in
ठंडा
UK, London.
थोड़ा अलग दो दे जरा और ये जरा दे उठा कर कुशन Lavanya, how you in yellow looking very
Good. How are
good.
you, ma'am? Thank you so much.
Good.
Nothing as much to match you.
अरे यार क्या
आप तो
बात
ever young हो, ma'am.
where are you traveling?
नहीं, ma'am, नहीं. I'm here now.
You're here now.
Yeah.
Okay. Yellow suiting like anything. Very good. Looking very refreshed.
Refreshed. Yes. आप कैसे हो, ma'am?
मैं गुड हूँ सोचा चलो आज अच्छे लावण्या को बहुत दिन बाद मिलूंगी
I know, I
अनुराधा
know.
So
को भी
shall we
आपको
go
आप
live
आपको
now?
मिलना ही है हमें इसार में.
Sudeep ji?
मिल नहीं पा रहे ना बहुत दिन से
I know, I know.
ब्रिज वाला को भी बहुत दिनों के बाद देखा है
वाला
आपको
मैडम तो
मिलूं।
पूरा बिजी हो गए.
नहीं ऐसा नहीं है पर ऐसा होता है ना सब वो कब बहुत सारे हो गए तो
हाँ,
सिलेक्टिव हो
बहुत
गया
सारे.
कोई किसी एरिया में जा रहा है कोई किसी में सो इट्स नॉट यूनिफॉर्म तो अब सारी एआईसीओजी में मेला होता है इट्स डिफिकल्ट टू फाइंड टू कैच एनीवन
आप लोग इसार 2027 में ब्लॉक कर दीजिए, मैम.
गुड
आप लोगों को इधर ही रहना है.
कहाँ है ये
बैंगलोर 2027
बेंगलोर
फरवरी.
ठीक मैं
Bangalore?
अभी आज ही कर देते अच्छा बेंगलोर
हाँ.
आईसीओजी जा रहे हैं अभी फिर
हाँ, आईसीओजी के लिए हम मिलेंगे, तभी मिलेंगे, मगर इसार इम्पोर्टेंट है.
अच्छा अभी तो मिलोगे ना
हाँ,
लावण्या
मैम, मिलेंगे, मैम.
चलो तुम तो फिर अपने उधर ही रुकोगे ना
हाँ,
यू
हाँ.
हैव योर रेजिडेंस देयर ना
हाँ, मैम. We're on the other part. I'm on the extreme end of Bangalore, Electronic City.
Bangalore
anyway
is
we'll
a,
catch each other
I know. Archana madam, hello.
Hi Lavanya, how are you?
Hi, I'm good, ma'am. I'm good.
Good. Let's start. I think
Yes, ma'am. We are
5:15.
ready to start.
Sudeep ji, start
We are
kar
ready.
dijiye live.
We go live in
Sudeep
3
ji, live.
Hi.
Yeah, Dr. Anuradha
Kalpana, are
is
you
here.
taking?
Hi, Dr. Archana. Good
Hi,
We are
evening.
live
hi
now.
Anuradha. Are you also in Scotland or London? Where are you?
I am in Mera, India only.
Acha, I thought you've been Ishri. You must have gone to
No,
Ishri.
I didn't go.
Yeah.
We went for Aspire to
हाय
China,
अनु
so we decided not to go.
अनु तो आज कश्मीर की कली बन के आई है अनु
Hi, Tarni
फ्लोरी
ma'am.
फ्लोरी फ्लोरी अनु
कैसे
We are
हो
live
आप?
now.
Woman, start now.
Yes, ma'am. Hello,
Komal?
am I audible? Yes.
Yes,
Yeah, you
Okay,
are
okay.
audible.
Yes.
Please go ahead,
Yes,
Doctor.
Komal.
Yes.
Start करिए.
Good evening, everyone. I welcome you all on behalf of MP ISAR Delhi, Karnataka chapter, and I'm really happy to see you all here, and I'm looking forward for today's session. So I will invite Forma Med Dr. Sudeep ji for the lamp lightning session, please. Thank you, Sudeep ji. So, before further delaying, I would like to invite Dr. Rudri to continue with the today's academic session.
Thank you so much, Dr. Komal. And myself, Dr. Rudri Agrawal, I extend my heartfelt welcome to all the senior faculties, all the expert speakers, and all the chairpersons who have joined us across the India. And a special invite and a special welcome to this three states webinar, which is extending from Delhi, from the north, covering MP, and going up to the southern part of India. So, a very, very warm welcome to each and everyone present here. And this has been possible just because of the vision of Dr. Archana Basir ma'am. None other than Dr. Archana Basir ma'am, can bring every one of us on the same platform. And continuing this webinar series since so long is really, really adorable. So, ma'am has given all us the opportunity to be on the same platform and to interact with each other and to learn from each other's experience. So, thank you so much, Archana ma'am. Now, without much ado, let me have the CV of Archana ma'am, please, so that I can introduce and welcome the program director, Archana Basir ma'am, for all of us. Thank you so much. So, Dr. Archana Basir ma'am needs no introduction, but just to introduce ma'am is the presently holding the position of chairperson MP ISAR from 2025 to 2027. Ma'am has been vice president of Foxy 2020. She is a fellow representative of AICC RCOG West Zone. Ma'am is also joint secretary of ISPET 2025 to 27. Ma'am has been an organizing secretary of AICOG 2021 Indore. In past, ma'am hold various prestigious positions like chairperson Foxy Imaging Science Committee 2015 to 2017, organizing secretary of ISAR 2026, managing committee member of ISAR 2018 to 20, managing science member of EFOG, imaging science committee chair CEFOG 2020 to 23. And most importantly, ma'am is the Foxy presidential candidate for the election year 2020-26. And ma'am is heading Akash Hospital Indore, and ma'am is serving as the director and a senior IVF consultant of Indore. We extend heartfelt welcome to you, ma'am, and we wish that this election year could be one of the most memorable year in your life, and we can see you as our president. So, our heartfelt wishes to you, and over to you, ma'am, for the further proceeding for the session.
Thank you very much, Rudri, for a kind introduction. At the outset, I would like to extend my warm welcome to all the three states of our ISAR who have joined in today. I'm really grateful to my secretary, Dr. Brajbala, who has really been instrumental in connecting with Dr. Lavanya, Dr. Seema Prakash, Dr. Anuradha, Dr. Gunjan, Dr. Sunita, Dr. Astha, Dr. Smiti, Dr. Mekhala. And I think even sitting in Scotland, she has been continuously messaging me that Madam Dr. Shilpa will join, Dr. Renu, Dr. Richa, Dr. Tarini, Dr. Sujata Agrawal. So my welcome to Dr. Anita, Dr. Dipti Logane, Dr. Neha, Dr. Shweta, Dr. Yukti Bharadwaj, and Dr. Parul Khanna, Dr. Kalyani, Dr. Dipti Gupta, Dr. Akriti, Dr. Divya, and Aishwarya. And the pillar are Dr. Rudri, Dr. Kalyani, Dr. Komal. What we have done so far, let me just brief you with our series. We started our series on 8th March 2025, and each webinar we have kept one focus topic, and till date we have connected with almost 600 faculty members and so many delegates, and we do have the keep the recordings of the session as well, and those who are missing to attend, Sudeep ji does forward the recording. So the whole purpose of creating this platform is to connect with the colleagues from the different states and take their inputs on the same topic and spread the knowledge to all our members. That is whole objective of our series. So in today's series, we have included, I'll be speaking on role of ultrasound in fertility, in assessment of infertility. Then we have Dr. Seema Prakash. She'll be talking on premature ovarian insufficiency. What are the current guidelines? And we have very, very excellent panel where it will be moderated by Dr. Lavanya, Kiran, and Anuradha. They will be telling us how to prepare the soil. We have experts, Tarini, and I'm really looking forward for this webinar where we are just talking about the basics. It is not only for the infertility or IVF specialists. What we are trying is to engage the general gynecologist to learn basics of infertility. So I welcome you all on this platform, and I'm really grateful for all of you to have joined and spared your time in spite of your busy schedule. Somebody has been operating, like Seema has been operating for 5 years, and everybody is even in the consulting. But I think gynecologists are the people who have great capabilities and capacity, and they really are multitasking. Even at the same time they are doing their webinars, they are seeing their patients. I think our brain's chemicals are different than the chemicals of any other specialty or people, because I really say that we should pat our back for the work we are doing in throughout the day. Now I would like to have a little inputs from both the chairpersons of Seema Prakash from Delhi and Dr. Lavanya Kiran from Karnataka about this webinar. And I'm really grateful that they have spoken to their members of ISAR Delhi and ISAR Karnataka, and asked them to join on the webinar, and everybody has happily come on this. So over to you, Dr. Seema, for your inputs on 3-state combined webinar, and Dr. Lavanya, to you as well. And Dr. Seema, just a...
Thank you, ma'am. Thank you.
Thank you,
Thank
Dr.
you
Seema
so
first.
much. And in fact, it is a privilege to be involved with you in such a elaborate webinar. And the thought behind this webinar is really great, that you are involving 3 states together. Usually people do not involve so many people from outside. So I found it so interesting that we will be contacting on the same stage on the same day in 2 hours, and we will be knowing each other very well in this webinar. And I talked to Dr. Lavanya also last night only, and it was so nice that we could at least contact each other and know each other, that yes, this kind of connection is there. It may be due to ISAR or Foxy, whatever it may be. But one thing I'm sure, ma'am, that the kind of modesty, Archana ma'am, you have, it is very rare to find. Like, I met you in Indore also, but I know very few people with such a status are so modest. So I'm really grateful to you for involving us. And Delhi people, like I have involved in Delhi, I have kept in my team very young, dynamic members. Like mostly they are young and dynamic members. And along with that, we have people like Dr. Tarni ma'am who are on in the capacity like advisors. So we have such kind of diversity here, and I have included everyone here, and I have sent these messages to all the people in ISAR. They will be joining because most of us are, as you rightly said, that we are multitasking, somebody is busy somewhere, and then ultimately everyone is happy to join. So thank you so much for including me here.
Thank you, Dr. Seema. You have included young, including yourself, because we all are young, because we all are working and very enthusiastic. So that's very nice of you, nice inputs, and it's good to connect from north south. So it's like a our family, which is on one laptop. We can connect with everyone. So over to you, Lavanya, for your inputs on 3-stage webinar.
Thank you, Archana ma'am. I think this is a wonderful initiative, I would say. Like Dr. Seema mentioned, young, energetic, you are the top on the list of the youngsters there with energy, looks, everything. And when I read the 3 states, I was reminded of the 2 states book. So, and like that, you are also energetically, enthusiastically connecting all 3 different states with the same energy. And this is going to be a rocking thing. I'm not sure. I've never heard anybody do this before. So I think you are known to do something different, something unique and great, and it's not just, you involved the chairperson, the secretary, everybody was involved. Their members have been involved. They don't, not even just the executive committee members, even just our KISAR members, they were so excited to be a part of it. And that's so great. And like Seema madam mentioned, all of us should connect. We have wonderful secretaries. I too have the best in the world. Dr. Anu is with me. And it was so nice talking to Dr. Brijbala, Gunjan, all of them, and that I think really we're feeling like a family. These 3 states, I think, is going to be like sisters forever. And thanks to you. The credit is entirely to you.
Thank you, Lavanya. And it is really nice to connect with you all. And I think, Dr. Brijbala, you can now start, say something, and we can start with our webinar.
So good evening, everyone. And it's my privilege to work with all of you together. And we thought that we will be taking one from north and one from south or east and west, so that there are different category of patients. Like in some states, PCO is most common. In some states, late marriages and poor ovarian reserve, or some places there is thin endometrium. Sometimes there is adenomyosis. So we will get inputs from every sort of this thing. And it's great to have all you here. And MPs are Karnataka and Delhi all together, seeing so vibrant. Everyone is looking so happy, and I'm thankful to Dr. Archana Base ma'am for giving me free hand. Whatever I'm thinking, madam is always saying, go ahead. So this month, as we are going to celebrate 25th July World IVF Day, so I thought, why not to keep something like boosting eggs and making soil prepared for better outcome. So welcome all. Thank you so much for putting your efforts on this. Because I am traveling in plane, so I can't speak now. Thank you so much. And Dr. Komal, you can go ahead with this.
And now I think we can begin the scientific program. Yeah, Komal.
Komal, please unmute yourself.
Okay. Yes. So, good evening, everyone. And I would like to invite Dr. Rudri to invite all the chairperson for the first session for today. Today's topic of the first session is evaluation of infertility with ultrasound. And our speaker is going to be Dr. Archana Base ma'am. And I'm looking forward to hear from you, ma'am.
Thank you, Komal.
I think it
Thank
might
you
be
so
good. It might be good to just introduce in one line all the chairpersons, Komal, Dr. Sunita Arora, Dr. Smiti, Dr. Astha, and Dr. Mekla.
Yes.
So, yeah, just
Yes.
introduce
So it is my
chairperson.
privilege to invite Dr. Sunita Arora ma'am. She's Yes, ma'am. So I would like to invite our chairperson, Sunita Arora, ma'am. She's HOD senior consultant at Bloom IVF, and Fortis, she's director at Sunita Arora Clinic at Safdarjung. We would like to invite you, ma'am, for today's seminar. Can I have the CV of Dr. Astha, ma'am? So Astha ma'am is principal consultant and unit head at Make Super Specialty Hospital, Patpatganj, and she is also a part of laparoscopy and hysteroscopy committee of ISAR. We would welcome you, ma'am. The next chairperson is Dr. Smiti Jain, ma'am. She's senior consultant at Motherhood Hospital, Noida, and Women's and Child Clinic at Greater Noida West. And I would like to invite Dr. Mekhla Dwarkanath B, ma'am. She is a medical director and senior consultant at reproductive medicine at Icha Fertility Solutions. And ma'am is also a chief of clinical research at Icha Fertility Solutions. So please join us, ma'am, for the chairperson.
Thank you. Thank you.
Yes. I would like to request Dr. Archana Basir, ma'am, to start today's session.
Yeah, definitely. Can I share my slides? Yeah.
Yes, ma'am.
Hi, very good evening to all of you again. And thank you, chairpersons, for coming over to chair the session. I've kept my talk very simple and very just focused. Role of imaging in evaluation of infertility. I think in the modern time, we cannot really expect in practice of infertility without ultrasound. And modern gynecologists have ultrasound probe in one hand and laparoscope in another hand. Just this is the ultrasonographic anatomy. I'm not going into much detail of, like, we know that transvaginal ultrasonography is kind of our third hand or third eye, you can say. So this is the ultrasound sonographic anatomy. Whenever a couple is coming to us for evaluation of for infertility problem, I think the first investigation which we offer, apart from after taking history and clinical examination, is the ultrasonography of the pelvic organs. So this is the ultrasonography. What you see is in a sagittal section, uterus, myometrium, endometrium, and then this is the shape of the uterus, which is the normal shape, and this is the stratum basilis, stratum functionalis, and inner myometrial junctional zone. Now, what I always tell in my most of my lectures is that it is very important to evaluate the myometrium, because you can see endometrium or the endometrial canal by hysteroscopy. You can see the serosa, you can see the fibroids, you can diagnose small endometriosis spots by laparoscopy, but myometrium cannot be seen by anything except the ultrasonography. So it is very important, and we all know that myometrium plays a very important role in fertility as well, because the blood supply to the endometrium comes via the myometrium. So these are the inner junctional zone, this is the middle layer, and this is the outer layer of the myometrium. If you look at the normal anatomy, this is a normal endomyojunction that has to be seen, and we know that there are two common pathologies which does affect the fertility. One is the adenomyosis and another one is the fibroid. So what happens in the adenomyosis, there is loss of endomyojunction, and you look at here, the shape of the uterus is globular, and these are called the, basically you can say Venetian blind or salt and pepper appearance, and endomyojunction is lost. And there is a NUSA guidelines, there is a direct evidence of adenomyosis and there is indirect evidence of adenomyosis. So that is about the adenomyosis, and this is normal endomyojunction, triple layer endometrium, and this is what everybody likes to see, whether it comes to your ovulation induction or your IUI or in IVF. Now, next once you have done the assessment of the uterus, assessment of the follicles, to know why do you want to assess the follicles in a routine gynec practice, when you're just doing the infertility practice, even whether you're doing IVF or not doing IVF, assessment of follicles is to know if follicle is mature and is going to yield a good quality fertilizable ovum, to limit incidence of multiple pregnancy one of the biggest complications of ovulation induction. And just to make sure that endometrium is ready to accept an embryo, that you're going to be listening in the our panel discussion also. And there's a beautiful picture here, a dialogue between hormone and vessel. Nowadays, with good high resolution ultrasound available, what we have is, this is a normal physiology picture which we have learnt in our PG, UG days, that there are two phases, follicular phase, luteal phase, and this is the hormone changes which happen during a menstrual cycle. And when you are following a woman during her fertility treatment, that's how you are going to follow. You do the 4 scans, minimum 4 scan, day 3 baseline scan, day 7 or 8 scan, day 14th scan, pre-ovulatory scan, and please do not forget to do the luteal phase scan. And nowadays you have the Doppler available. Do put the Doppler around the follicle and see how much is the periphery of the follicle is surrounded by the blood vessel, and you calculate the RI and PI, and that really helps you when you are planning your trigger. So how many scans in one cycle? As I already said, baseline scan, day 3 scan, enteral follicle count, ovarian volume, day 7 scan, pre-ovulatory scan, and luteal phase scan. So this is how we do the scan, and this is the picture I have kept in my OPD. When a couple comes to us, what are you going to be doing? What you mean by follicle study? So this picture we have, we tell them that, look, we are going to assess on day 3. We give you ovulation induction, and this is how the size of the follicle will grow. This is the blood supply, and that is the pre-ovulatory follicle, and this is the corpus luteum, and it's the luteal phase scan. So that really makes them understand what is the follicle study, what you mean by follicle study, and sometimes they take the picture of it and they try to compare it with the picture we give it to them, and then it really helpful if you have a pictorial display, that it helps when, if somebody is not having good like poor responders, they are not responding well, you try to explain them. So that is very, very helpful if you have a pictures like this in your armamentarium. And do measure the enteral follicle count. You know, if less than 5, poor responder, 5 to 12 are good responders, and more than 25 hyper responder, which are going to go into OHSS. So I just brought one case to highlight how important the ultrasonography in management of the infertility. And one more thing which is very important is, a sonography has to be done diligently, very good sonography, because you really can pick up the problem with a good sonography rather than patient going from one place to another place. This is a very recent case which we dealt in the last week. A husband came to me with his wife's report, and he said that couple was 30 years old, no comorbidity, average BMI, cycles were regular, lasting 3 to 5 days, and they were trying to conceive since 1 year. And husband has been diagnosed with severe asthenozoospermia. She has undergone 2 cycles of IUI. She was diagnosed with left-sided tubal blockage and hydrosalpinx on HSG after doing IUI. So you can pick up the points from here that before doing IUI, ideally many of us would do the tubal functional check, but it was done after the 2 failed IUI. Now husband came to me that they have been advised IVF and wanted an opinion prior to that. So I insisted that, look, IVF or no IVF, I cannot comment unless I've seen the patient. I would like to assess myself. So very next day he came with his wife, and we took a history and found that she had progressive dysmenorrhea, scanty menses, initially had pain on her left side and was diagnosed with some cyst for which she had taken treatment. She recently started having pain on her right side also. We did a pelvic examination and found tenderness, and so we decided to do a transvaginal sonography, and these were her findings. I'll come to the findings. These were her findings. Now, what I'm trying to tell here is that patient sometimes might not be willing to do sonography if they have recently done a sonography, and sonography pictures may not be very clear with a very clarity. Now it is such a clear picture. You can see here, these are the ovaries which are kissing ovaries, and you can see there's a ground glass appearance. This is an endometriosis, already stage 4 endometriosis she has. Though she has been advised for IVF, but she doesn't have a diagnosis. She will require treatment for that. and there is no good follicles are seen around this ovaries. So I think this ovary already is being damaged. She had pain, and if somebody would have done a scan or treated this endometriosis, her AMH when we did was a very low AMH. So this probably tells us, and this is a very recent scan, this tells us that whenever you are doing a sonography, it cannot be just taken casually. Infertility sonography has to be very, very directed sonography, and we should be able to diagnose the problems 90% by doing a good sonography. What I was trying to tell you, show you here, if you see very carefully, even by a good scan, you can see the ureter also on the scan. Endometriosis scan has to be learned, and it is very easy. One can learn the endometriosis scan, and you can see. So we will be offering her an MRI as well, because we need to see the status of the ureter when we are planning a surgery for her. So this is important, that do a good scan, even look for the ureter, because I'm telling, I had to do a one of my patient, young girl, 22-year, we needed to do nephrectomy because her ureter was engulfed and she had non-functioning kidney. So do a transabdominal scan also in an infertility case, especially if there is endometriosis, and do a transvaginal scan. So what we did the kidney scan as well to assess for if there is any hydronephrosis in her. So it is important that if you are doing an infertility scan, please do a scan where you are seeing the ovaries not go beyond enteral follicle count, go beyond endometrium, and look for the full pelvic assessment by the ultrasound. So what I am coming to the end, is it okay to miss an obvious diagnosis of endometriosis in this day and age of ultrasound and let the disease progress? And how would you proceed further? The panelists can take up in the panel, and should ultrasound be part of initial assessment of every patient with infertility? My answer is yes, it should be the part of initial assessment. Just do a history and a thorough assessment by a gynecosonologist. I have come up with a terminology, gynosonologist. So gynecologist with sonography acumen will be the people who will be assessing it well. So that's what is from me, and thank you very much for your patience listening. And I hereby request you to support and vote for me for Foxy President this year. I'm with you, I'm for you, and I'm by your side. So I'm always going to be for your side, and please support and vote for me. Thank you so much. And next, let's listen to the next speaker.
Thank you so much, ma'am, for your insightful session. It is always a delight to hear from you, and definitely all the points we have to keep in mind while dealing an infertility patient. I would like to invite all the chairperson to put their remark. Dr. Astha ma'am, Dr. Mekla ma'am.
Ma'am, definitely you have already said everything, and we are too naive in front of you to add much. But still, ma'am, the problem that we encounter, like if you work in an infertility clinic, it's definitely the scan is done by the fertility specialist. But what the routine radiologists do and send us the scan during follicular monitoring, they usually mark 1 or 2 follicles, and they don't do that exact follicular monitoring, which plays difficulty in our day-to-day practice. And moreover, ma'am, especially when the patients come with the diminished ovarian reserve, and when we say that there are no follicles on the day 7 or day 8 of ovulation induction, then they really, when it becomes hard for them to accept that. So the scans, as already told by you, should be very in depth and should be done preferably by some fertility specialist.
I can answer this question very, what we really have to do is to ask. Unless you ask, you don't get anything. So I think you should have a group of the radiologists. I'm not saying that radiologists don't do good scan or they wouldn't do. So a group of radiologists whom you are commonly referring to your patients, you can just request them that, look, I'm sending this patient for follicle study, but please spend a little 2 minutes extra and give me all the information. Or maybe in a form which you are sending, request slip you are sending, just do not write only the follicle monitoring. Just put a pelvic scan. So every scan of the follicle study should be a pelvic scan. So that will probably help and increase your, pickup rate of the problem.
Yeah, definitely, ma'am.
Yeah, ma'am, probably like you said, even if we are not able to do all the scans, probably it is helpful to ask the radiologist that this is what we want, because invariably we do come across with similar situations like what you have said, that they're just going on doing either TI or IUI, without addressing the actual issues. Like, already IUIs have been done, and later on you realize that there is a hydrosalpinx, and a good scanner they would even pick up a hydrosalpinx. There are
Exactly.
some cases where on day two, you may not be really able to pick up the hydrosalpinx. In many of our cases, we have seen that normally the hydrosalpinx becomes very evident only in the mid cycle and towards the later half. We feel like it unless it is really big. And sometimes these something like a thickened tube-like structure we have seen. We don't know like when to do scopy or when not to do, because sometimes the patients are also very tricky. If you ask them for laparoscopy, how justified are you? We're not very sure that every tube that is thick will be hydrosalpinx. So a careful scan will definitely be very helpful. And when there is a HSG or a HICO-C in place, I think that becomes a very important tool for counseling of patients as to who requires a laparoscopy, and probably like a thorough evaluation before doing an IUI. To have the tubes checked also play an important role is what I think on that.
Rightly said, Dr. Mekla. It is rightly said, because what is happening, that as you said, that the hydrosalpinx becomes evident because under the influence of hormones or whatever. So, really a counseling has to be done prior. And, it is disheartening for the patient, and it is challenging for us to really do the counseling in infertility. I think it is every infertility case is your exam.
Dr.
And it's
Archana, may
very
I ask
hard
one
to say
question?
also when they ask why did the previous person did not pick up also. We cannot tell anything. We just have to say it might have. So it's always better to keep a protocol in place is what I think.
Yes, yes, you cannot tell that your colleagues, or maybe, it was not there that time, so you cannot say. Yes, Dr. Tarini, you wanted to ask
Yeah,
something.
I was asking really excellent. You can like visualize the ureter. So what are the my tricks and tricks to see the ureter in the TVS?
Tricks to see ureter in
Yeah,
the TBS. I
and
think it is very important. You just have to, like put your probe in the posterior fornix and just elicit the sliding sign. And if there is a sliding sign, you know that ureter is not involved. And if there is sliding sign is absent, and you just have to put your probe, you can even pick up the rectal nodule, you can pick up the ureter. Beautifully, you can see. Only thing you need, Dr. Tarini, is the patience. Once you have a patience and you have ultrasound anatomy rehearsed, then it is not difficult. So, we are, I think, now into good endometriosis scan. So we are doing good endometriosis scan, and we can pick up whatever we are picking up, the same thing we have seen on the laparoscopy. When we do laparoscopy, we see that yes, our diagnosis was nearly 100%. If we say it is dense adhesions, and there are ureter is involved, so we know that. So I think it is very important in this era, when you are dealing with endometriosis and you know that there can be involvement of other organs, it's important that by ultrasonography, and if you think that they are involved, maybe to get an MRI done and do a transabdominal scan is very important before you put in your scope. It is important that a diagnosis and the extent of procedure which will be involved is already determined.
wow, really congratulations. Actually, I never seen, that's why I asked you. An excellent deliberation, Dr. Archana. Very
Thank you.
informative to all of us.
Thank you. Thank you.
Good.
Thank you so much. Yes, Anuradha.
Yeah, excellent presentation, Dr. Archana, as usual. It's nice to hear you. Now, I have, there is a new concept which has emerged, all of us know, that
you have to, if you are suspecting endometriosis, as you said, deep infiltrating endometriosis can be picked on scan if you have the eyes open and the nodules and all. Now it is also the thing has shifted towards not doing a surgery as a first line for diagnosing endometriosis is what we need to tell everyone. Because if there is a cyst, and if supposing the cyst is not huge, like 4 centimeter, 5 centimeter, patient has no symptoms, you don't need to go with a laparoscope. If AMH is borderline or low, we have to straight do IVF. So it is very important and imperative for all the gynecologists to understand that endometriosis can be picked on ultrasound.
Very valid point, because you should not be putting scope to diagnose endometriosis, which is 100% correct, because we have good non-invasive modalities to diagnose even deep invasive endometriosis, and there is a idea classification, stepwise diagnosis of endometriosis by ultrasound. So I think that from this platform we want to say that before you really embark on laparoscopy, it is very important that you are going in for treatment of the condition, not for diagnosis of condition.
Great. Thank you, ma'am. Dr. Smriti, ma'am, and Sunita
Or
Arora,
maybe
ma'am.
next talk, yeah, whatever. Yeah, if there is any
Yes,
comment
ma'am.
or any question.
No questions, ma'am. It was a wonderful presentation, and I think all the topics have been discussed by other people also, and valuable insights. Thank you so much for the presentation, ma'am.
Smriti.
Thank you, ma'am.
So now moving forward to our second session, the topic is going to be POI and infertility, the latest guideline. And our today's speaker is going to be Dr. Seema Prakash, ma'am. It is my delight to welcome you, ma'am, for today's talk. May I have the CV? So, ma'am is a senior consultant at UCMS and GTB Hospital, and ma'am is also chairperson as ISAR Delhi from 2026 to 2028. Ma'am is a committee member of many organizations, and ma'am is also a chairperson of AOGT committee. And ma'am has received.
Thank you, Komal. I think that's enough.
I know Seema is a very nice person, very good human being, and I just met her at ISAR, Yuva ISAR in Delhi, and we had a good bonding. So,
Yeah.
Seema, welcome
Thank
to
you, ma'am. Thank you so much.
We welcome you, ma'am, for today's
Yeah.
talk. So I would like to invite today's chairpersons, Dr. Shilpa ma'am. So Shilpa ma'am is a managing director at the Siri Care IVF Center in Mysore, and ma'am is also a principal at International Institute of Assisted Reproductive Technology and Research Center and College of MSc of ART and Embryology, Mysore. Ma'am has received a lot of awards, and ma'am is also organizing committee member of KISA 2025 conference. We welcome you, ma'am, for today's talk as a chairperson. And like everybody knows Brajwala Tiwari, ma'am. We welcome you, ma'am, for today's talk. Ma'am is a chairperson at Foxy Environmental Health Committee 2025 to 27, and ma'am is MP is our secretary. And today's session is because of ma'am and Basir ma'am. So I would like to invite you, ma'am. Today, ma'am is traveling, so she might not join us. She might not stay active for today's session, but we would like to hear from you as well. May I have the CV of Dr. Renu Tava ma'am? So Renu Tava ma'am is Director and Professor IVF Coordinator at MAMC New Delhi. She has organized CMEs and conferences on IVF, and ART is organizing secretary, and ma'am is also treasurer of AOGD 2016 and 17, and executive member of IFS 2022 to 2024. We welcome you, ma'am, for today's talk as chairperson.
Thank you so much, Komal.
Ma'am. And I would like to invite Dr. Richa Sharma, ma'am. Ma'am is Director Professor at Department of Obstetrics and Gynecology at UCMS and GTB Hospital, Delhi. Ma'am has received Foxy Korean Award 2015 in junior category. We would like to invite you, ma'am. So I would like to invite Dr. Seema Prakash, ma'am, for today's talk as a speaker. Can we have the slides, please?
I will be sharing.
Okay, ma'am.
Is my slide visible?
Yes, ma'am.
Yes, ma'am.
Ma'am, make it full screen, ma'am.
Okay, fine. Is it there?
No, ma'am.
It's not full screen. Just go on slideshow. Yeah, it's there now.
Yes, ma'am.
Yes.
Yes, ma'am. Perfect.
So thank you. Thank you for such nice introduction. And my topic is premature ovarian insufficiency and fertility. I'll be talking about the latest guideline because the management of premature ovarian insufficiency has undergone important updates in recent times with publication of the latest guidelines which are evidence based by jointly developed by European Society of Human Reproduction and Embryology, ASHRE, American Society of Reproductive Medicine, ASRM, and International Menopause Society also. So these guidelines are now considered the international standard for diagnosis and management of POI. So what is the definition? Definition of POI, I will be talking like not in full the premature ovarian insufficiency. I'll be calling it POI. So it is defined by loss of ovarian functions before the age of 40 years. And it is characterized by amenorrhea, irregular cycles with elevated gonadotropins and low estradiols. It has to be differentiated from usual age of menopause. So if it is after 40, like 40 to 45 years, it is called early menopause. And if it is beyond 55, it will be called late menopause. So these are the definitions basically. Now coming to prevalence, basically non-iatrogenic POI, if we talk about, it was in older studies, its incidence was prevalence was only 1%, while it has now increased almost to thrice the number, like 3.5% in recent publication. So very high number of cases are now seen. So what are the risk factors basically associated with POI? So it has, because it has got long-term health consequences on fertility, bone health, cardiovascular health, sexual health, psychological, neurological health. So every effort should be made to reduce the risk of POI. So there are many modifiable factors also, which include gynecological surgical practices like oophorectomy and surgeries for ovarian malignancies or benign ovarian conditions. Then lifestyle factors such as smoking, treatment regime for malignant and chronic diseases. Women with risk factors for POI are identified and counseled regarding POI risk and fertility preservation. So there are various factors related to these, like genetic factors, which is quite common as a non-iatrogenic cause. Around 16%, 15.9% of the cases have been seen due to genetic causes. It was seen by the study by Sylvan in 2023. Then family history of POI is also very important because the risk is increased almost to 18-fold in first degree relatives, and fourfold increase is seen in second degree relatives, and 2.7-fold risk raised in third degree relatives. Then ethnicity, it is prevalent in Asian women compared to other world countries. So when we come talk about the iatrogenic causes like chemotherapy or radiation, then pelvic surgery, we just recently discussed endometriosis surgery, ovarian cystectomy, bilateral oophorectomy. These are iatrogenic causes. Then non-iatrogenic causes. So the non-iatrogenic causes include genetic causes and autoimmune causes, and then the last one, but not the least one, rather this is the biggest cause of POI, that is idiopathic. So it constitutes around 37% of the cases, and around 34% are iatrogenic. So we have to be very cautious about that. And others like autoimmune and genetic are lesser in number. Then what are the symptoms? Symptoms are basically estrogen deficiency, symptoms, women with presenting with the symptoms along with irregular menstrual cycles or secondary spontaneous amenorrhea for at least 4 months. And you must consider and exclude the diagnosis of POI in women aged less than 40 years who have these symptoms. So POI symptoms, when we talk about like hot flushes, hair loss, fatigue, sexual problem, insomnia, they are quite common. But mood swings is more commoner in these patients. And other symptoms like muscle pain, joint pain, palpitation, tingling, these are seen in 3 out of 10 patients. So, what are the possible implications for relatives of the patients who have POI? So, female relatives or such as sister or daughters with non-iatrogenic POI should be counseled that there is an quite high increased risk for developing POI in themselves. Then female relatives are offered support regarding the increased risk of POI, and ovarian reserve testing may be helpful in these patients for fertility issues, because later on that will not be treatable. Then female relatives should also be informed about the signs and symptoms of POI and should promptly seek medical advice if the diagnosis is made. Female relatives should be informed that there is no established method for predicting or preventing POI. Some relatives may wish to consider family planning and fertility preservation options. So that has to be told to the patient as soon as we make the diagnosis. So when we talk about the flow chart here shows that how to go in a case which presents with a spontaneous secondary amenorrhea before the age of 40 years. So first thing is elevated FSH concentration, which is more than 25 international units per liter. In earlier guidelines, we used to repeat the FSH concentration about after 4 weeks, and that was diagnostic of POI. But now the latest guidelines suggest that there is no need to repeat the FSH concentration. Only single reading is sufficient for diagnosis. Suppose the patient has undergone bilateral oophorectomy before the age of 40 years, or there is a history of previous chemotherapy, pelvic radiotherapy, pelvic or ovarian surgery, then iatrogenic POI diagnosis is made. In those cases, there is no need to do even FSH also. Then genetic testing, if that is abnormal, I will be discussing about the genetic testing also. Then if that is abnormal, the cause should be diagnosed as genetic cause, and we should refer these cases to genetic counselors for and follow up, and we should follow these patients. Suppose genetic testing is also normal, then we have to go further for autoimmune testing for hydroxy antibodies and TSH screening and additional autoimmune antibodies depending on history and examination. Then diagnosis of, if that is abnormal, then diagnosis of POI due to autoimmune causes should be made. And if all these are still normal, everything you have done and that is normal, then the diagnosis should be confirmed as idiopathic POI. So FSH, when we talk about FSH, the threshold varies with very poor evidence based. Previous history guidelines, as I told, that FSH above 25 was considered as mid-cycle surge, but there is no evidence base to change that. But FSH and clinical picture, there is no need to repeat FSH values. Estradiol, there is worse evidence and huge variability. So, to ensure FSH is not suppressed by sporadic high estradiol, then only we can do this. Otherwise, there is no uh, uh, evidence to suggest that estradiol should be done in all the cases. Then FSH does not have to be timed according to the menstrual cycle. As such, these patients become amenorrheic, then only we do that FSH. Only one report according to latest recommendation. Estradiol not recommended for diagnosis of POI. A low estradiol concentration indicates hypoestrogenism, and in combination with elevated FSH concentration provides additional confirmation of POI diagnosis. Coming to genetic testing, as I told you, that the commonest is Fragile X syndrome. That testing is recommended in women where we do not find other causes. So for non-iatrogenic POI, and wherever available, after comprehensive genetic testing, counseling, and the patient should be offered further genetic testing if required. Then screening for autoantibodies should be performed if genetic testing is normal. And anti-ovarian antibodies should not be used to diagnose autoimmune POI. Thyroid function test should be assessed by measuring TSH levels at POI diagnosis, and it should be repeated every 5 years whenever we find the symptoms related to thyroid. Do not routinely perform thyroid peroxidase TPO antibodies screening as part of testing for autoimmune causes due to high prevalence of positive TPO antibodies in general community also. So when we come to evidence, chromosome analysis testing is recommended for all women with non-iatrogenic POI, strong evidence. fMRI permutation Fragile X testing is recommended for all women with non-iatrogenic POI, that is also strong evidence. And where available, after comprehensive genetic counseling, additional genetic testing like next generation sequences can be offered to women with non-iatrogenic POI and identify other potential genes that may cause POI. So this is a conditional thing. Then there is a guideline group recommend that age of a woman with POI should not be used to restrict access to genetic testing. Like we should not say that she is beyond 40 or around nearing 40, so we should not do genetic testing. Then immune testing, there is strong evidence to do 21 hydroxylase and autoantibodies test in women with unknown causes. And anti-ovarian antibodies should not be used to diagnose autoimmune POI. That is also a strong evidence. Thyroid should be assessed, strong evidence. Anti-TPO antibody screening as part of testing for autoimmune causes of POI due to high prevalence of positive TPO antibodies, it is not does not have a strong evidence, so not to be done routinely. Then there has been analysis of various sorts related to POI and fertility, and it has been seen that only 4.8% women achieving pregnancy in observational studies compared to 1.5% in control studies. So establishment and maintenance of pregnancy using in vitro fertilization and ovarian embryo donation in a patient with primary ovarian failure has been shown to be useful. So other potential intervention for patients with POI, like in vitro activation of follicle growth in biopsies, ovarian tissues, administration of mesenchymal stem cells, injection of platelet-rich plasma into the ovary. So that is also a conditional document for iatrogenic causes of POI. Fertility preservation can be considered prior to treatment. The guideline group also recommend that fertility preservation is discussed with the women at risk of POI because in most women with POI, there is no opportunity for fertility preservation as the follicle pool is depleted later on. So what are the obstetric risks? So there is a very strong suggestion, evidence that women should be reassured that natural pregnancies after idiopathic POI or most forms of chemotherapy do not show any higher obstetric or neonatal risk than in general population. So natural pregnancy is safe, but oocyte donation pregnancies are at high risk and should be managed in a appropriate obstetric unit. Women and their partner should be encouraged to disclose the origin of their pregnancy to the obstetrician. Then pregnancies occurring after radiation to the uterus are at high risk of obstetric complication and should be managed in appropriate obstetric unit. Pregnancy in women with Turner syndrome are at high risk of obstetric and non-obstetric complication and should be managed in an obstetric unit with cardiologist involvement. Now coming to the treatment, HT is recommended for women with POI until usual age of menopause is reached for primary prevention to reduce risk of morbidity and mortality, whether there are symptoms or not. Then there is recommendation that healthcare providers advise women HRT does not provide contraception, so they require assistance in their family planning. There is a recommendation when women with POI reach age at which usual menopause occurs, HCPs consider the need for continued hormone therapy based on personalized risk, benefit assessment, and current evidence. There are various regimes available in hormone therapy. Sequential combined or continuous combined may be used, but in POI, the main importance is the doses. It is almost the double dose to be given in these women, like 1 milligram if it is given the micronized progesterone. Oral dose, it has to be more than 2 milligram of micronized progesterone. Same is for with the dydrogesterone. If it is given as 1 milligram, it is given as 2 milligram dose. Estradiol also different forms are available, like there is patch, gel, sachet, gel pump, spray, and oral preparations are there. It can be given as sequential combined or continuous combined HRT. So, and progesterone also, progesterone or progestrogens can be given in these women. Same, the dose is almost double except for norethistron, which is given in almost the same dose as other HTs. This is the management algorithm which we just discussed. When we take history and examination, we go according to the history and examination, whether it is iatrogenic and non-iatrogenic. Then investigation should include the complete workup: renal function, liver function, bone density, vitamin D, cardiovascular status, lipid profile, fasting plasma glucose, HbA1c. Then there should be lifestyle management should be advised to these patients, like smoking, cessation of smoking, exercise, diet, healthy diet, and weight-bearing exercises, calcium intake, adequate vitamin D, and alcohol intake should be reduced. Then psychological health, counseling about the psychological issue should be there. Fertility, as I have already discussed, that fertility issue has to be all discussed as soon as we come to know that this can be a case of POI. Then systemic hormone therapy or local hormone therapy as per the symptoms. Then bone and brain health and sexual function and genitourinary symptoms. They have to all to be managed by these patients. Key consequences of untreated POI are various, and they include hypertension, dyslipidemia, cardiovascular disease, stroke, diabetes, dementia, then various menopausal symptoms, infertility, mental health issue. Overall quality of life is deteriorated, osteoporosis, decreased muscle mass, decreased survival. Thank you so much for your kind hearing, and I, on behalf of Delhi ISAR, thank the MP ISAR and Karnataka ISAR for giving this opportunity to Delhi ISARians. Thank you so much.
Thank you so much, ma'am, for such an insightful and well-structured presentation on premature ovarian insufficiency and infertility. And I would like to invite chairpersons for their remark. Dr. Shilpa,
Just
ma'am.
want to add one thing over here, Dr. Seema. Am I audible?
Yes, ma'am.
Like we are seeing lot many patients with POI, and now as environment committee chair, I'm reading a lot about this, and I found that there are many literatures that air pollution and noise pollution affecting even the microplastics. They are affecting the ovarian reserve, not only ovarian reserve, but in overall in male infertility, spermatogenesis and gametogenesis, all are affected by this. So whenever we are seeing a patient with poor ovarian reserve, we should take history, occupational history, and any exposure to these pollutants like air, and sometimes just giving them this advice and antioxidants may give some good fertility, although we have to see the patient in whole, as you said, bone health and cardiac health. But This I want to add on. Thank you so
Yeah,
much.
actually, there is a very high spike in the cases of POI. Like earlier, when we used to run this HT clinic, we hardly found POI cases. But now in my HT clinic, I have 48 cases of POI. So the incidence is quite high nowadays. So it is related to basically the environment, also the lifestyle and diet. Everything is responsible for that.
Can I just add few comments, Dr. Seema? Ma'am, it was
Yes, sure,
marvelous
doctor.
and
Yes.
very comprehensively you told us all about PY. I think it is very important. And even I'm in a government setup and I see a lot of these young girls coming up with so much low reserve and it's really shocking. And I
Yeah.
think as an infertility specialist, we just keep on seeing that ovaries and all that. But I think because of so much high risk they are, we have to treat these patients in toto. And
Yeah.
even what you said, I do agree because these girls which are coming up now because of this stress factor, because all of these usually you don't find many of the causes, idiopathic is coming, and then this sleeping habit. This is also playing a lot of role in their lifestyle,
Yeah.
because they sleep late, they have eating disorders. All these things are playing a lot of havoc in their life. And I think very good presentation. Thank you so much, Dr. Seema.
Thank you
Thank you.
so much. Thank you.
Seema ma'am, I just want to ask you here because since you told TSH has to be measured and as a test for autoimmune. So, if do you think like all patients with increased TSH, we should consider them as autoimmune and just treat with the thyroxine? Like, what is the this thing behind
See,
it?
if TSH is deranged, then it has to be treated anyhow. And it depends on the value of TSH. Like if it is very high or very low, then obviously we have to find out the other causes also. Otherwise, if it is just abnormal,
Because
we treat.
you mentioned that anti-TPO antibodies doesn't play a role here. Like, I mean,
Yeah, there is
generally it
very,
increase in,
yeah, the
yeah,
evidence,
yeah.
according to the latest guideline, there is
So
not much
that's a
evidence.
very good point. Like the recent guidelines which you have enlightened us, because we routinely used to do anti-TPO antibodies as soon as we see high
Yeah, so
TSH.
that difference is there this time, no? And they have
Yeah.
asked to not to repeat FSH also because that
Yes.
confuses more than of help. And same is for
Even many guidelines don't recommend anti-TPO antibodies. If the TSH is high, that has to be treated. This as simple
yes,
as that. And
yes,
infertility, you have to keep the thyroid within that. That could be one of the
yes.
reasons that she's
That
not
is the
getting
only thing.
pregnant.
Yeah.
And even if the patient is not infertility, but TSH is high because of other factors, because of a bone mineral density, we have to treat TSH, high TSH. Anti-TPO has
Ma'am,
no role now. I do
it's
agree
not
with that.
a part of treating. I'm just like wanted to confirm with whether we should consider it as autoimmune only, like when the high TSH
Yeah.
we see.
Yes, definitely. If you have a
Sometimes,
cause, definitely.
yeah.
You have.
And one more thing is, should we have to add on AMH along with FSH to just to
See, they
give a
according to the
convincing
latest
evidence?
guidelines, yeah, AMH, they have not recommended AMH until unless we find that fertility issue is there and we find that we need to find out the reason for that, only then AMH. Otherwise, for POI, they don't, there is no evidence as such for considering these patients for this thing. POI.
One other thing I want to add on here, ma'am. Since you mentioned that that's the thing what we do, we go for egg donation in case of a POI because that's the treatment what is we think it's the best. We should always counsel the patient. There is still 5 to 10% chances of spontaneous conception, even if she's a POI, because we have seen cases where we counsel them for egg donation. Sometimes they may not agree and they may come after 6 months with a spontaneous pregnancy. So that should be really mentioned in the first in the place. Like there is a chance, but though the chance is very less.
Yes, there is always a chance of spontaneous conception. And even these idiopathic, when we do not find any this thing, and if they bleed on our treatment, there are chances of spontaneous conception quite good. So that is there. And even their obstetrics is also low risk.
So the net crust is that never tell a patient that you can't get pregnant. So that's
Yes.
the mantra of that. We should
Because
never tell a
this,
patient,
if
even
you tell
senior is
them
a,
that
yeah.
the periods are not going to be there for you and pregnancy will not be, so that is devastating for such a
Yeah.
young patient. And I have seen a girl of 23 years with POI. So that is theirs.
Yes,
We
ma'am.
cannot
Even
just
yes.
tell them this.
No, we are coming all within 30s only with POI, ma'am.
Yeah.
Yeah, definitely.
I think very
I
nice
just wanted to
presentation,
add, ma'am.
Dr. Seema. Wonderful presentation. I think you have
Thank
beautifully
you.
covered all the recent guidelines and all the
Yeah,
work
I
on
wanted to in
algorithm.
fact cover
Yeah.
treatment in
Yeah,
detail,
and
but
even the
time
HP
did
also,
not
I think
permit.
you have really made up this your presentation. It was really sufficient, and I must really congratulate you for a wonderful presentation.
Thank you.
And,
Thank you.
congratulations and best wishes for your successful tenure also. You're doing great,
Thank you.
actually.
Thank you so much. Thank
Nice
you.
talk, Dr. Seema. It was really excellent. I think we need it. Updates. What to use, what to do, what not to do. Very nice. So
Thank you,
very,
ma'am.
very
Thank you so
happy to
much.
hear.
Seema ma'am,
Thank you.
really great presentation. Really nice. Enjoyed listening to you. I just wanted to add to what Dr. Shilpa was asking. I think TPO is more like antibody testing. If it comes positive, it just indicates that low dose for a longer duration is required. So that's the only indication. So there's no need to repeat or something. Once it's positive, it's like it's just that it says, yeah, you will have to continue for a longer duration.
Yeah.
And like Seema madam mentioned, I think we cannot be God. So you cannot say 0% or 100%, because I think AMH is telling us about the quality, quantity, more of it. So, even if you have one or two or randomly ovulating patients and they conceive, I think, yeah, there is chances. So I don't think that we should be telling zero and tell them, yes, lower chances of conception, but that is how they have to choose
There
the
is
treatment.
one more aspect to it. If TPO antibodies are positive, patient will need more intensive monitoring because the dosage required may keep on waxing or waning. So, yeah, a closer monitoring is required. That is another thing. So if you get Dr. Seema, somebody is talking on your behalf at some other
I
place.
think Dr. Renu has written my name by
No,
mistake.
I didn't write that name when you just gave me that Zoom link.
I
I
think
just
they've
clicked
sent
on that.
personalized links for on the email.
You can
Yeah,
change your name.
no,
Renu,
no, that's okay. I don't mind
Okay,
that.
I don't know.
Renu, you can change the name.
It's okay. No, because
Okay,
I
I think
tried
this
so many
idea has
times
been
to
given
join
on
some.
my name only.
So you passed that. I just joined that, and I was seeing that's coming as that.
Renu, you can change. Rename कर लो.
she changed. Yeah, she
चलिए
really
कर
changed.
दिया. Thank you so much. Thank you.
She's super fast. She changed it already.
Yeah, great, great,
चलिए,
great.
thank you.
Thank you so much, ma'am, for the wonderful discussion. So now moving forward to today's panel discussion, I would like to invite our moderators, Dr. Lavanya Kiran, ma'am. May I have ma'am's CV?
I think we've anyway been introduced.
That is very much kind of you, ma'am. So, Lavanya, ma'am is a director and lead consultant obstetrics at Repromed Robotics, Kims Hospital, Bangalore, and ma'am is a chairperson of Karnataka chapter ISAR and joint secretary of Fertility Preservation Society of India as well. We welcome you on the behalf of MP ISAR, Karnataka and Delhi ISAR chapter, ma'am.
Thank you, Dr. Komal. Thank you. You're a very sweet girl.
Thank you so much, ma'am. And I would like to invite Dr. Anuradha Khar, ma'am. Ma'am is the Secretary of Karnataka Chapter ISAR and a member managing committee of ISAR 2026 to 28. And ma'am is also a Secretary ART Committee, Karnataka State Obs and Gynae Association. And ma'am has ma'am has received ISAR Dronacharya Award in 2025 Foxy Badlab Award in 2019. I would like to welcome you, ma'am, as a moderator for today's panel discussion.
Thank you so much, Dr. Komal, and thank you, Dr. Archana and Dr. Brijwala, for inviting us today.
I am very much delighted to invite our today's expert, Dr. Tarini Taneja, ma'am, and Dr. Sujata Agrawal, ma'am. So Tarini, ma'am, is a past chairperson of ISAR Delhi and is a director of Indian IVF Center Delhi and director is Taneja Test Tube Baby Center. We welcome you on behalf of MP chapter, ma'am.
Thank you, dear. Thank you, Komal.
Thank you, ma'am. And I would like to invite Dr. Sujata Agrawal, ma'am. Ma'am is a senior consultant at Indraprasth Apollo Hospital, Delhi, and is a vice chairperson of ISAR Delhi as well. So thank you so much, ma'am, for your presence. I would like to invite our today's panelist, Dr. Anita Rajoria, ma'am. Ma'am is presently a head of department and senior consultant at the Hedgewar Arogya Sansthan Government of NCT of Delhi. And ma'am is also associated with Asia and Ocean Asia Federation of Obstetrics and Gynecology and FOXY as well. And ma'am is also a patron and past president of Delhi Gynae Forum of Southwest and past chairperson of Adolescent Health Committee. And ma'am has received a lot of awards and
Thank you, Komal. Thank you for in one. I think that is sufficient. Thank you so much.
thank you so much, ma'am, for joining us today. I would like to invite Dr. Deepika, ma'am. Ma'am is a senior consultant obstetrics at obstetrician at New Delhi, and ma'am is also a clinical meeting coordinator of ISAR Delhi chapter.
ये
Thank
चार्जर
you so much,
उठाना
ma'am, for
जल्दी
your
से।
presence. I would like to invite Dr. Neha Varun, ma'am. Ma'am is a national master trainer of Implanon, and ma'am has received award of Kamini Rao Oration Award at 2022. And ma'am has done more than 100 publications at national and international journals. And ma'am is also a member of Foxy Medical Disorder in Pregnancy and Foxy Clinical Research Committee. Ma'am has a special interest in minimal invasive surgery as well, and maternal and fetal medicine as well. Uh, I'm delighted to welcome you, ma'am, for today's panel discussion. I
Thank
would
you.
like, thank you, ma'am. I would like to invite Doctors Shweta Sardana, ma'am. Ma'am is a obstetrician consultant at Jeevan Jyoti Clinic and Hospital at Dilshad Garden. Ma'am is a executive member of Delhi chapter ISAR and joint secretary as well. Ma'am has received a gold medal at AOGD 2009 for best paper presentation and gold medal for NARCHI 2011 for best paper presentation as well. I would like to invite Dr. Yukti Bharadwaj, ma'am. Ma'am is a consultant at Benison IVF Noida, and she has received first prize at National ISAR Quiz Ahmedabad at 2026 and second prize winner in quiz at ISAR 2024 and Yuva ISAR 2023. Ma'am is also a recipient of Delhi ISAR Appreciation Award 3 years consecutively. We are delighted to welcome you, ma'am, here for today's
Thank you
panel
so much.
discussion.
Thank you, Archana ma'am, Rajbala ma'am, Seema ma'am, for the kind invitation. Thank you so much.
Yeah. I would like to invite Dr. Parul Gupta, ma'am. Ma'am is a senior consultant and IVF specialist at Nova Center at Vasant Vihar. And ma'am has received award of ISAR Mayor Youth Icon 2023 and AOGS Kavita Vapat Award of Scientific Excellence at 2022. And ma'am is also organizing committee member at Foxy Scientific Sangam in 2023. And ma'am is also has been faculty of AICOG at 2029, 2022, and 2023. We welcome you here, ma'am, today.
Dr. Komal.
I would like to invite Dr. Kalyani Srimali, ma'am. Ma'am is a senior fertility consultant at Nova IVF Fertility Center, Indore. I'm delighted to welcome you here, ma'am. I would like to invite Dr. Dipti Gupta, ma'am. Ma'am is an associate professor at NSCB Medical College, Jabalpur. She is a consultant and unit head at Ankur Fertility Clinic, Jabalpur, and also secretary of MPOX 2024 to 2026. And ma'am is also a West Zone coordinator of Foxy Quiz Committee as well. We welcome you for today's panel discussion, ma'am. I would like to invite Dr. Akriti Lamba, ma'am. Ma'am is the executive director of Indira IVF Indore, and also ma'am is a director at Cluster Business MP Chhattisgarh and Indira IVF. And ma'am is also a member of ISAR and ISHAR as well. And ma'am has a special interest in pre-genetic screening and testing and repeated implantation failure and recurrent miscarriage cases. We are delighted to welcome you here, ma'am. I would like to invite Dr. Divya Venugopalan, ma'am. Ma'am is a fertility specialist, and she has done her FRM and FMAS training as well. And ma'am is also a member of Karnataka ISAR as well. We are delighted to welcome you, ma'am. Ma'am is working as a fertility
Thank you.
specialist at Cloud9 Fertility Center. Thank you, ma'am. I would like to invite Dr. Aishwarya, ma'am. Ma'am is also a fertility specialist at Cloud9 Fertility Hospital, and also working at Tamara Hospital and IVF Center. Ma'am is also a member of Karnataka ISAR. We are welcoming you here, ma'am, for today's panel discussion.
Thank you. Thank you, everyone.
Thank you so much, ma'am. So I would like to invite Dr. Lavanya, ma'am, and Anuradha Khar, ma'am, to start today's panel discussion.
Thank you. Thank you, Dr. Komal. So I think we've all had a long day post OPD. I'll simultaneously start sharing my screen. So I think we all had a wonderful, lovely OPD, lovely academic session. And I think that's really great that where we are mixing our weekday with such a wonderful initiative. So consider this like a movie flow because we will be talking on case scenarios just like the movie or just like our day-to-day life stories which happen. So we have wonderful producers. Our main producer for today is Dr. Archana Baser. Thank you so much, ma'am. Co-producers Dr. Lavanya and Dr. Seema, and wonderful directors Dr. Anuradha, Dr. Brijbala, and Dr. Gunjan. So, I think you heard Dr. Archana speak so well on how the endometrium is so much important, how the embryo is so important in order to get the best of the results. We heard Dr. Seema Prakash talking about PUI. What do we do? Because all of us at the end of the day, we want a good embryo, good pregnancy, good live birth rates, and that's what's important. And with me, I have a wonderful director, Dr. Anuradha, the best in the world I could have as my secretary. I welcome Dr. Anuradha as well to join us for this moderation. And the main lead for our movie today is Dr. Tarini Taneja, madam, and Dr. Sujata Agarwal, our lead actresses, beautiful looking actresses for the day who will lead us through this. And we have this is a multi-star cast, I would say, where we have Dr. Anita, Dr. Deepika, Dr. Neha, Dr. Shweta, Dr. Yukti, Dr. Parul, Kalyani, Dr. Deepti, Dr. Akriti, Dr. Divya, and Dr. Aishwarya. So all of you are going to take the lead. Why I said all of you are lead actresses, multicast, because I'm going to keep it flowing. I'm not going to pick on anybody because I want the light to be falling on all of you. So please feel free to pick up the questions and answers. No pointers. So without any delay, we'll go into the cases because we're running short of time. We'll have wonderful interactions as well. Our first case, we had Mrs. A who was married to Mr. X. They were married for 11 years. She had a pregnancy, but unfortunately, at the end of 2 months, baby died because of milk aspiration. Now, they've been trying for almost 8 years, but they've come in with secondary infertility. On evaluation, AMH was 4.9, FSH, LH 4.3 and 3.6, thyroid 3.4. SSG was done where both the tubes were bilateral tubes, no spillage seen. The husband's blood test was done where everything was normal, semen analysis was normal, except that 3% normal forms were seen. She underwent diagnostic histrolab as well because SSG didn't show any spill, and they're like, we'll see again. So when we went in the intro op, we could see that a cocooned abdomen, TO mass was there, tubercular nodules on the pelvis. We did take a biopsy. We didn't do any interventions. What could be the diagnosis on the look when you go into the abdomen? You're seeing this kind of a picture.
Tuberculosis.
Genital
Yes.
tuberculosis.
Perfect. Perfect. So diagnosis of tuberculosis was done, and patient took ATT for 6 + 3 months, and then 6 months and post that it wasn't. The physicians said, okay, 3 more months, and then she was declared disease free. So we decided to go for IVF because, she went through a COS. ANTAC protocol was used. 16 oocytes were obtained. 14 M2. ICSI was done. And 12 cleaved embryos were seen. So almost 8 CGB embryos were obtained. We prepared her endometrium, and then these are our endometrium. So it was only around 6.4 maximum, whatever we did, we got 6.6. Hazy triple line pattern, poor vascularity. What would be your steps next?
So before embarking on preparing the endometrium, I'll just like to add one point here, Lavanya. Now, the recent guidelines, RNTCP also says that for genital tuberculosis, only 6 months ATT is enough. So
Correct.
intensive phase 2 months with 4 HRZE and then 4 months of HRE. So that
Correct.
is one thing. I think you must have consulted physician. It's all right, but this is something new I
Yeah.
learned
I
recently.
thought I'll put that across, but I thought you would anyway guess it with the FSH-LH ratio, which was done, that it was a little sometime back case,
Yeah,
not a
yeah,
recent
yeah,
one.
yeah.
So I thought I'll
So
put it when I said, but I thought you'll all guess it when I
yeah,
said
yeah,
FSH bar
that
LH
is
ratio.
great.
Yeah.
So now we'll start, working on this patient. We'll start
Yes.
building up this endometrium for that matter. So over to
So
you again.
my question would be like, now when we say 6.6, 6.4, poor vascularity, we know it's a thin endometrium. I want you to tell me, what is the definition of a thin endometrium? What is the cutoff, and how should we go about this?
There is still a dilemma about the definition of what is a thin endometrium. Universally, some people have taken as 7 mm and at places even 6 mm, but there is no actual cutoff because thickness simply will not decide what is the fertility potential or receptivity of this particular endometrium. There are so many other factors which will determine how this patient is going to respond to your IVF cycles. As far as endometrial receptivity is concerned.
Pattern
Perfect,
of the
ma'am.
endometrium and blood
Yes.
flow is also very important, ma'am, more than just the
Yes.
thickness of the endometrium.
Perfect.
Now,
Perfect.
now the
Dr.
concept of
Lavanya, can I add actually, ma'am? So
Yes,
like
ma'am.
in IVF we are doing, so we just know that that thickness can't reach the threshold of embryo implantation. And various studies define the endometrium less than 7 a.m. on the day of SCG trigger in the fresh cycle and day of progesterone in the frozen cycle. That
So
is
less than
matlab, there
7
is a
mm is the most common.
yeah, less than 7, though pregnancy has happened in the 5 point something.
Yes.
But I mean, the IVF, they have done just like this studies, many
Correct.
studies.
This is
Even the
why we
ASRM,
labeled.
yes,
And it
ma'am, even the
depends more on the
ASRM
receptivity. It depends more on the receptivity.
So
Even
this is
H-ray
why
and
we
ASRM have
labeled.
given the definition as less than 7 mm.
Yeah.
ASRM 2022 and H-ray
Mm.
2023 has defined
Yeah.
the thickness less than 7 mm as thin endometrium. And since she's taken ATT, she's been a known cause of tuberculosis. We know that in genital TB, almost in 80% cases, the endometrium and the uterus is affected. The tuberculosis affects the basal layer of the endometrium, so it causes a permanent damage, causing adhesions in the endometrium. So it's a difficult case if it is
Perfect.
a genital
Basically,
TB.
madam,
Perfect.
it is not, it's basically, it is the thing is the threshold of that each woman, because every woman is different. Like for this case, okay, fine, it is around 6 mm, but it's ultimate the threshold, like in which type, like which, maximum threshold she can reach the endometrium and she can conceive, because we have seen cases where patient has conceived at 6.5 also, 6 mm also, if the triple layer is there and the blood flow is good. It's not that it's ultimatum, her threshold is what is her maximum. We cannot say that it is only, it should be 7 mm or 7.5 mm. It can be at anything, because that's her threshold level, maximum level is that much. So I think so we need to consider that one also.
Concept of
Very.
seed and soil is always there. It depends
Yes.
on the concept. What is coming in is also important. So
Yeah,
definitely.
yeah.
Perfect.
And it's
This is
just
why I
not the
think we
thickness.
labeled Tarni madam and Anita madam as the lead actresses, and we have wonderful multi-star casting here and so well put forward. So there's no universally accepted definition. Yes, thin endometrium, anything less than 7 mm, like Yukti said, 7 mm is the cutoff. Though there have been pregnancies low rates though, even at 6 millimeters. And thickness, like I think Divya put it across, thickness is not just the representative for a receptive. And like Aishwarya brought in so many points, there have been pregnancies, even when the thickness is a little lesser. Just the ET is a poor predictor for implantation. So increased ET always, of course, increases the good clinical outcome with good vascularity. All those things are something important for us to consider. Yes, we have enough of journals coming through saying that, you don't have to cancel if you see a good flow, all these things. But then I think all of us do get worried thin endometrium. How many of us are going to transfer at 6 or 6.6? It is a little jittery situation. Now you see this kind of a patient. What all things would you consider doing to improve for her?
Changing to
Definitely, we
natural
need
or
to improve
stimulated
the
cycle.
vascularity. Vascularity of the endometrium has to be increased. We can use supplements such as aspirin, low molecular weight heparin can be used. PRP and stem cells, they do hold a place. They are still under research, but in if there is a cause like tuberculosis, where, as I said before, the basal layer is affected. So there is a role of PRP and stem cell also.
And first change
So,
in
ma'am,
try for
also,
natural or stimulated cycle. So sometimes the natural thickness may come up to be more than the artificial cycle or the HRT cycle.
Also,
also
the
when you
amount
have
of
said that
estrogen
the
that this patient
endometrial,
has been exposed to. I mean,
uh,
what is the current dose of estrogen that she's taking? So that can also be increased. And
Change the formulation.
yes, from you can actually add in a little bit of vaginal estrogen also, or some estrogels also. And in my practice, I've seen actually it improves a lot with GCSF also.
so, ma'am, when you mentioned that the endometrial sample, a biopsy has been taken and a hysteroscopy was done, we are assuming that endometrial sample was also taken for biopsy.
Yes.
So, if apart from TB, PCR, and all, we could also rule out chronic endometritis. We usually do in such patients where they have been failed cycle, we check for chronic endometritis by sending sample for CD138 as well. So, before starting on the changing my treatment protocols, I would like to do a biopsy in failed cases. And then obviously, majority of the time during stimulation, we have an idea about how the endometrial thickness is going to be. So if it is during stimulation, also it is around 6.5, 6.6, we know that this patient has a threshold wherein the endometrial thickness is going to be around this much only. So obviously, as Dr. Shweta said, that we may change the protocol if we feel that during HRT preparation the endometrium is even lesser than what it was during stimulation. Then the change of protocol helps. At times, yes, we can increase the dose of estrogen. We can change the route by using vaginal or giving gels. And then there are a lot of adjuvants to improve the blood flows. Though the evidence usually does not support many, but obviously, when we are dealing with recurrent implantation failure or such cases, we usually like to add on. So I usually add on low molecular weight heparin or aspirin, and sometimes GCSF and PRP. Recently, I've also started doing mononuclear cells for my patients.
I think Parul very well taken your points. I think it is important that while we do this, also check on the chronic endometritis, treat them. And I love the points Shweta and Divya put across, changing the protocols, changing little preparations for your endometrium. Yes, is going to make a lot of difference. And like Yukti mentioned, all the adjuvants that, can be considered. Yes, PRP and stem cells. I will not consider it as experimental for thin endometrium at least, because I think now we have sufficient data. And especially in tuberculosis, what happens, like I think Yukti mentioned, the basal layer is damaged. I think PRP and stem cells, we are all aware how the growth factors work, how angioneogenesis starts happening, how newer regenerative cells, because that is what is damaged in tuberculosis, that's all coming up. And yes, maybe exosomes therapy, and I will say is experimental, but I think we have enough data for PRP and stem cell for thin endometrium. I'm not talking about ovarian regeneration, please remember that. And yes, we do have quite a few studies. So this is why I said I'm not going to call it as a research methodology. There have also people being using GCSF. Yes, I think aspirin and all of us use in our practice. So strong evidence for PRP and stem cells have been there compared to anything else. And
And
estrogen, I think Shweta mentioned adequate dosing, changing into vaginal routes will also help. I think we've covered here, the endometrial biopsy was done. She was treated for chronic endometritis as well. And in our case, we are on a peer review place where we are publishing a study on thin endometrium for tuberculosis patients. We did stem cell therapy for her, and her thickness increased to 7.5 millimeter with triple line pattern. And that is when the transfer was done. She was, like I said, this is a very old case of ours. So day three embryos were transferred. Now she's delivered, female baby, 38 weeks, 3 days. Elective section was done. Baby's almost now 4 years now. I request my co-moderator, Dr. Anu, to take into the next question.
Yeah,
Dr.
thank you, Dr.
Lavanya,
Lavanya.
anybody
Ma'am?
is doing the endometrial scratch these days or not? And though botulinum toxin is under research, but anybody
Mm-hmm.
doing endometrial scratch or SCG use putting and
We
GNRH
don't do
agonist?
We
electively
don't.
scratch, ma'am, but
As
then I
a,
feel
yeah,
whenever we are doing an hysteroscopy or we are doing a PRP, I feel it's like you're still meddling with the
yeah,
endometrium. So it's almost
and
similar because you're going in, coming out. It would almost act like that. But per se, scratch per se, I don't think it is, proven now or. We have data where only scratching doesn't help, but
and doc-
all of you can give your perspective.
Hysteroscopy will be a better option, ma'am, in
That's
this.
right.
yeah,
Yeah, yeah,
hysteroscopic
Coalition
definitely.
scratch
can be done in the same at the same time.
and
Same time. That
PRP
would be
has its
better.
role.
Yes.
PRP has its role in this case.
Yes, yes, ma'am. Definitely for
Yeah,
tuberculosis and all, because the basal layer
yeah.
is damaged and we know
This
how
is
it
real
works.
damage.
The only advantage between the PRP and stem cells, because we have a publication of 110 patients, I have seen in our practice that PRP, when we do, it stays for a little lesser time. We would say 3 to 4 months. But when we've done stem cell, the effect has stayed as close to 6 to 7 months as well. That's the greatest advantage that we've seen in our practice over these many cases that we took it up as a study. But yeah, so
The
response wise, yes,
effect,
momentary, everybody
yeah,
did well.
effect of PRP depends on how we prepare and how
Correct.
we activate the growth
Uh,
factors.
Yes,
That's
that's one
the
of the
score.
limitations
Yeah.
I feel even for the ovary,
Mm,
because our
mm.
data, though it said 13% conceived for POI patients, the problem is there's no standardized protocols. There are no
Protocol for
standardized
preparation.
methods of what is the better way to spin. All
Prepare.
those things are there, and yeah, not great results for us to talk too much about it. But we have to remember, though lesser people have success rates, at least they have their own progeny, because it's very difficult for people to be pushed for a donor cycle. Acceptance, I would still say, is very difficult or a little more pushy we have to be for them.
Yeah, we go on to case number 2. Mrs. X of 39 years, married to Mr. Y, 46 years. They're married for last 12 years and they come with primary infertility. Menstrual history and medical history is normal. Tubes are bilateral patent. Wife CR investigation show AMH of 0.36, FSH 9.6, LH 4.6, TSH 3.8. No, NTTPO is normal. AFC 6 in previous day 3 scan report. Husband has no significant past history. He's not a smoker. And semen analysis shows oats. And next slide, please.
Sorry. Yeah.
So oligoasthenoteratozoospermia is there for this patient. And DFI is normal. Next slide.
Coming.
No.
Sorry, it's moved. Are you able to see now?
No. Resume slideshow is there.
You can see, ma'am, you have
Uh-huh.
gone ahead.
So we know that her AMH was low, so she underwent a controlled ovarian stimulation, antac cycle. 4 oocytes were obtained. Pixie was done. They got 2 M2 and one 8-cell grade A embryo, one 8-cell grade B embryo. Fresh ET was done. Patient did not conceive. So anyone can answer. We know which group she belongs, but just we want to revise the Poseidon. Which group does she belong, Dr. Parul?
He belongs to group 4 Poseidon criteria.
Yeah, and they have done an antac cycle already, and I think they just got two grade A, one grade A, one grade B, 8 cell. My question is, should they have gone to a blastocyst stage in this patient? Is
Definitely,
one
definitely.
question. Yeah.
Yes. So one is that I would personally prefer doing a blastocyst transfer, uh, and also give the option of a genetic this also, because the age was 39 for the female.
But
Yes,
Dr.
39.
Parul, here we have a little bit catch because we got only one grade A cell embryo and one was grade B. With just these two embryos, is it justified to go to blastocyst? Is my dilemma.
Ma'am, yeah. So the thing is, we have to counsel the patient that when we are doing a cycle, when the number of eggs are less, obviously doing a day 3 transfer is only when we are not getting enough number of embryos. And to begin with, we know that in such cases, we are not going to have enough embryos. So we always have to counsel them that there is an option of doing a day 3 transfer, or otherwise, if we take them to day 5, there can be a growth arrest and we have no embryo transfer at all. So just for the that sake, if the patient is okay in going ahead with the day 3 transfer, then we do a day 3 transfer. Otherwise, I would also give them the option of pooling embryo.
Okay.
Then at least in the
Does
next cycle, I
anyone
take all the
differ?
embryos to day 5, and I would like to do a.
So does anyone differ in this management of going to blastocyst with just one grade A embryo?
So since there is only two, I mean, embryo,
One
so
grade A, one grade B,
one
madam.
grade
Itself,
grade and
day
one
3
grade
embryo.
C. So I would not, disappoint the
There are
patient. If it doesn't grow to blastocyst stage, then the cycle will be cancelled. So it's
high chances, yes.
better to take the chance.
Dr. Yukti, you have any difference in opinion
There are
of
high
going to
chances that will
blastocyst?
not progress to a blast, ma'am. Grade B, day 3 embryo. There are less chances of it going to a day 5 embryo. So we might
Yeah.
not have any embryos on the day 5.
So
So
not to
anybody
disappoint
wants to
patient.
add? Yeah.
Ma'am, so
Okay,
I
so
want
Patients should always be told about the
Counsel.
option of embryo accumulation actually, and not
So
progress.
embryo pooling will be
Yes.
a good option for this, low ovarian reserve patient,
Yes, ma'am.
and plus her age also.
Correct.
So, what would we do now? They want to, now whatever is done is done. They want to go for another IVF cycle. So, before that, would you like to do something? In poor ovarian reserve, some add-ons, something different plan of management, or a different protocol, Dr. Divya?
Try somatotrophin, ma'am.
Yeah.
Or
Anyone
do
can
Coenzyme
answer.
Ma'am,
whenever
ma'am, with point
any
three,
estrogen pre-treatment.
no, with point 0.3 AMH, I think so with the age of 39, I think so we can give a trial of PRP infusions for the ovarian, increasing the reserve. We can try if she's okay with it. Otherwise, I think so pooling of eggs, and we have to tell the patients prior again that we have to do the same thing again, and if still continues the same thing, then we have to go for another options. I think so. PRP infusion is working out because we are doing some cases, and it has really improvised. At least the better quality of eggs we have got, and the embryo quality has also improvised. So and even the husband is also, there is an issue. So I think so we need to sort out the husband's thing also. So I think so PRP will be better, madam. I don't know how
And
much you agree.
and obviously, little bit of antioxidants for the husband also.
Yeah,
We will
yeah,
definitely
yeah,
give.
yeah, yeah.
Yeah, we will give for couple of months and put this lady on some add-ons. What is Dr. Anita? What is your take on CoQ10? It's coming up very well
Yeah,
nowadays. We
there are.
are using it for poor ovarian reserve
Yeah,
patients.
yeah. People strongly are pro CoQ10 because I've heard in so many conferences people are using CoQ10, especially in male partners for improving their sperm counts and motility, etc. And it has shown in effects. Also, the evidence also, sustains the theory that, of course, there is some improvement. Yeah.
Okay, I want the panel to tell us that is everyone using CoQ10 for
Yes, ma'am.
Yes,
coenzyme
yes,
for
Yes,
yes,
yes.
yes,
all
yes,
of us are using, even I am
yes,
using, Dr.
yes,
Lavanya is using. So
yes.
it CoQ10 does improve little bit of mitochondrial function because with ovarian aging the poor quality oocytes come, and it is now proven that there will be mitochondrial disarray in these patients, and this CoQ10 might rejuvenate that mitochondria. So we are on the right path there. DHEA, anyone? Like there was a time when DHA entered and we said now this is the drug which will be used, and we used right, left, center. And what is your take today on DHEA tablets?
I am still using, but
I'm
I
using, yeah,
feel that
75
it is more
milligrams for 90 days.
beneficial for patients who are slightly younger, not at this age group. No, I
Yeah.
mean like 40 and beyond, it is not showing any wonders.
Mm. Okay. So anyone else is using, not using? You can give your comments.
So
Ma'am,
I'm
75
testosterone
milligrams
gel
for
I
3 months.
use. I'm using DHEA, but not in the cycle of the stimulation in the previous cycle. And they say that there should be a washout time now for DHEA as well. Either you are using DHEA or testosterone gel. So there should be a washout time for at least 10 days before you start the stimulation. So I'm stopping in the cycle.
See,
Uh,
when the
then
DHA started, I remember they said you can give till the last day of stimulation, and then when you trigger, then you stop it. So yes, little bit change has occurred there. DHA, though, we do not have enough studies and meta-analysis on that. Earlier ones studies came that yes, you can use. So many people are. I was talking to some people, and many people have discontinued DHA, but yes, CoQ10 is common and everyone is using. What about growth hormone? Anyone uses? I mean, we'll discuss these add-ons one by one. Do you have any experience on growth hormone or
ma'am, growth hormone,
testosterone? Let's
Yeah,
take both
growth
together.
hormone,
growth
me using
hormone.
not to begin, not in the beginning of the stimulation, but if I see like on the subsequent scan when I call them, and if I feel that there is no growth, then very rarely in some patients who are affording, in those patients only using growth hormone.
Is
Yeah.
anyone else using
Yeah,
growth
yeah, yeah.
hormone?
Yes, madam. I mean, what Dr. Parul said, that actually it is really given benefits for certain patients, right, from the day 7 or day 8. It is really improvised, like whatever the previous what we have got, and now the eggs, the quality definitely has improvised. So I
Okay.
use it.
So I think, see, again, for growth hormone, we do not have enough
And much
of
evidence.
evidence as of now.
Data.
Many people are not using. Some are using, and as you said, it has a limited role. Limited role. It depends whether you want to use it or not, but you have to tell the patient that it does not guarantee, success, because the evidence is slightly low on this. What about LH now? We are talking addition of LH for poor
Yes,
ovarian
ma'am. Yes,
reserve,
ma'am.
poor responders. Yeah.
Definitely for poor responders, it is indicated because as it is this female in a higher female age, the androgenic activity is reduced. So LH will supplement that androgenic activity.
So,
And
Dr.
also
Yukti, do you use recombinant LH, RLH, which people have started using?
No, ma'am, it is very costly. I
Very
add
expensive.
HP, yes, ma'am, HP HMG to my recombinant FSH in such females.
Mm. Okay.
Guidelines also say that it should be in the ratio of 2:1, like FSH
Correct.
to
2
LH
is to
for these
run
females.
one ratio. Then melatonin, in between this melatonin came with the big bang. Anybody has used or has got any good results with it?
We can advise them to have a good sleep.
Yes. Best. Okay, can we go to the next
So,
slide,
ma'am,
please?
can I ask? I'm a core gynecologist, not IVF expert, but we have all IVF experts here on the panel. So, at what point of time will you be, because the patients keep coming from you to us, if we have sent the patient is not responding, then when would you be counseling for oocyte donation? Because that's at some point of time, if you are going to be looking at failure,
Okay, Dr. Parul, please
the
answer.
patient will come back to us. आप जब बोलेंगे तो patient हमारे पास
हाँ,
लौट के आता है.
okay. Dr. Deepika is asking. Now we have done
Yes.
one IVF for her, and she is the referring consultant for us.
Yes.
And
So patient
that
will come
patient
back.
did not conceive. Obviously, they go looking for their primary doctor who has sent it to us. And
Yes, ma'am.
obstetrician gynecologist would like to know, as an OBG who does not do hardcore IVF, that when should they counsel for donor oocyte at this step, or can they go for another
So,
own
ma'am,
self
I would,
cycle?
yeah. So, whenever a patient comes with low MH, especially at a high age like Poseidon 4, I think in the very first meeting only, when the patient comes, you have to give them all the options. For a self cycle, we have to tell them what are the chances with their own eggs, what are the chances going to be with the donor egg program, because it is cost. When they're doing their own cycle, when they're doing with a donor egg cycle, if they are keen on going ahead with their own cycle. Now there are some couples who want to do maybe 3 cycles, 4 cycles, and cost is not a factor.
absolutely.
And then there are couples who want just pregnancy, not very affording now, because donors are getting donors is also difficult. That adds to the cost of the donor also. So we have to give them this option from the beginning and let the couple make the informed choice. Also, when we are going to do embryo pooling, like in the first go, we have to tell them there are chances that they may require more than one cycle with their own eggs. That is the embryo
Yes.
pooling. So that is for them to decide that they want to do their own cycle once or then go straight for a donor. And when even if they're failing with their own cycle in the first attempt, next cycle when they come again, we have to do the same counseling, that these are the chances with your own eggs, and otherwise you can opt for a donor egg program.
So, Dr. Deepika,
Also,
I
ma'am,
think
we
you
have
got
to.
your answer. I
Yes, ma'am.
think, every IVF specialist, in fact, when patient conceives, believe me, I do not spend too much time with them. I just say congratulations and they go for the antenatal thing. When the patient fails, I take
Yes.
a proper, at least 15-20 minutes counseling session. And this is what Dr. Parul said. This is what we discuss again with them. You want to go for another cycle, or do you want to go? We do give option of donor oocytes because we have to inform the patient, and it
Yes,
depends
ma'am.
on the patient what they select. And then now this patient has come back, Dr. Yukti, she wants to try another cycle. Now what difference, how will you, any different modality you'll use in this patient, maybe change of stimulation protocol? Can I know she wants to do second cycle with you?
So pre-stimulation, we can give her antioxidants, testosterone gel. We have to change our protocol. In this kind of female, we can also try the mild IVF, ma'am, in which we are reducing the dose of the gonadotropin and adding an oral ovulogen. So it will reduce the quality, it will increase the quality of the oocyte and also reduce the dosage. We can
Okay.
counsel her for duo stimulation. This
Does
female should
everyone
be.
believe in mild stimulation here, the panelists?
No.
And
Mild
high chances
stimulation
of
came with
cancellation
again a
also.
big bang when it
Yes.
started,
Doesn't
and
help
we did
them.
it.
Came that way, that more chances of getting euploid embryos, even if the number of eggs retrieved were less, but there are high chances of cancellation in
Yes.
patients where the AMH is 0.3 or 0.2, like that. And
Yes.
as you said that you can add oral ovulogens. I personally have seen whenever we have added oral like clomiphene with gonadotropin, the growth has been very asynchronous. There will be 1 or 2 follicles which have moved ahead than the cohort. So that is the problem I have faced repeatedly whenever I've added clomiphene. So I'm not using it, though many people say that it reduces the growth of gonadotropins and they have got very good results.
Okay, now patient comes on
For
day
this
2
age
and
group,
you
actually,
see,
there is
yeah, Shweta, yeah. Dr.
for this age group, actually, there is a minimum number of oocytes that we need to get to actually get a euploid blastocyst. So the best for this age group is actually embryo pooling, a dual stimulation cycle for them.
Yeah, so we
With
are coming to that. Now, patient comes on day 2, and you hardly see 2 follicles on one side and 1 or 2 follicles on the left side, right and left. Would you start stimulation at that point, or would you wait, Dr. Shweta?
Ma'am, she is at a reserve of zero point 0.3 with an AMH of zero point 0.3. She is going to show two follicles on each side maximum. She will never show up 3 or 4 follicles. So we have to
Okay,
start. We
previous
have to
scan,
tell her
okay,
that
I'll
you
change
need
the
to do.
scenario. Previous scan, there were some 3 follicles on one side and 3 on one side. This time I have only 2 on one side and 2 on one side. So please
We
tell
can.
me, would you wait on this patient for say going to luteal phase and assessing again? That's my question.
Ma'am, even if with 3 and 3, we are not going to get all the 6 of them growing and get 6 in one attempt. She will have to be counseled that she will need multiple attempts of stimulation. So I think
So would you go for
we
a dual
can
stimulation
do
in
a
this
start for
patient?
her.
Would you go for a dual stimulation in this patient?
I personally will like
Patient
to
has
do
less
2
time.
separate cycles.
Okay.
Rather than
Okay.
doing a follicular plus a luteal, I will give a break in between and do 2 stimulations for her.
Okay. Anyone differs on this?
So, ma'am, if embryo
Ma'am,
pooling, is to be done, obviously there can be 2 ways. Either we do 2 different follicular stems, or as you said, if we have done a previous scan wherein we saw more number of follicles in luteal phase, I would also prefer a dual. In that scenario, I would also prefer a dual stem, considering the hormones and everything is fine. And also, as you said, in a dual stem or a follicular stem or rather a luteal stem makes more sense when the difference is sometimes even in a normal responder, we see that in follicular phase, the follicles seen are less as compared to luteal phase.
Yeah.
Here, if it is a difference
See,
of
it does happen many a times, and that is why
but in this patient,
the
if it is
reverse
only
dual stimulation is another thing which we want to tell our delegates about it. I think most of us know it, that there is something called as reverse dual stimulation. So you leave the follicular phase of this cycle, you start with the luteal phase, and then you finish the OPU, and then you start in that next follicular phase. Now, the advantage of this cycle, Dr. Parul, is that you can transfer the embryo as a fresh embryo transfer, because there is evidence about it that fresh transfer works better in the poor responders, poor ovarian reserve patients. And the advantage is that in case you've got a blastocyst in the previous luteal phase, you can think about an embryo transfer. So, anyone wants to add on this
Yeah.
reverse dual stimulation?
Hi,
Has anyone
everyone.
done this? Do you do
Can
it?
I can I
Dr.
just
Sujata, yeah, hi.
yeah, I'm
Dr.
sorry
Sujata.
I got late. I got stuck
No
somewhere and
problem.
my phone got,
Yeah, please
little
tell me.
long traffic. So I just want to know how many of you are really doing this kind of stimulation? Those who are sitting over here. What Anuradha is talking
No,
about.
no, we are not. I'm not doing.
No one is doing. So what is the take home message we are taking, and what for our day-to-day practice by this panel? Because suppose if you are seeing two follicles on day 2, what is the size of the follicle? Were they smaller or they were dominant follicles? or even 4 follicle, we can start stimulation. Because and if we are getting 4 good oocytes, we can do a transfer in same or next cycle in poor responders. So why we are always thinking of embryo pulling? And if you are not thinking of embryo pulling, how to start in luteal phase? Will you be doing a follicular monitoring in this? When will you come to know that actually the luteal phase is there and she has ovulated? So what kind of protocol you are doing, Dr. Nurada? This is my question for the panelists.
Dr. Sneha, is she there? Can't see.
I think we've already discussed the question
Yeah,
of
we've
embryo
discussed
pooling
that almost, yeah.
Yeah, but the question of embryo pooling came into the picture because the patient had already failed with the 8 cell embryos in the previous cycle, and we were wanting to consider a blast transfer. So, if we want to be secure that the patient has some embryos on day 3 in one cycle, we do an embryo pooling in such cases so that she has we can opt for a blastocyst transfer in the next cycle. Secondly, at this age, sometimes the patient comes that they want to have 2 kids in the future. So suppose if we are having, say, sufficient embryo, even a single embryo in that cycle, we can go ahead with transfer. But in case she gets pregnant in that cycle, and if she wants a future pregnancy, one more child, then we do not have any embryo. By the time she'll come for a second child, there will be hardly any ovarian reserve. So sometimes for that also we have to tell the patient of embryo pooling when the patient is with low ovarian reserve and at the high side of age. So,
And this is
if you
also
get
like
more
the
number of
yeah.
blastocysts now in this patient, you will go for a PGTA in this aneuploidy testing and all. Anyone on
Ma'am,
that?
if we have a lot of embryos, we should
It
counsel
is
them
better,
for
yeah,
PGT.
because she's
Ma'am,
39
I
already,
think
low AMH.
the
Yeah,
counseling
please.
for PGTA should always be done whether the number of embryo is small or more. We have to counsel them that this is the option which is existing when the patient is Poseidon 4, that is advanced age. Because when the cycles will be failing, we will be telling that your embryo needs a genetic testing. Since the number is less, we cannot do that. So the option has always to be given to the patient. It is for the patient to decide.
Yeah. So I agree with the panel that we have to offer PGTA seeing her age, and we can. So in this case, what was done is reverse dual stimulation, and with the addition of growth hormone, but fresh transfer was not done due to premature progesterone rise. So 3M2 were obtained, out of which only 1 day 6 blast was obtained in luteal phase. 4M2 with 3 good grade 5 blastocysts were obtained with this dual stimulation. FET-HRT was done, transferring one 4A blast, and she got her clinical pregnancy positive with cardiac activity documented on ultrasound. So definitely blastocyst pooling has helped, and this reverse dual stimulation has helped this patient. Yeah, next case.
Thank you.
Dr.
Yeah.
Lavin.
Do we have time for the next case, or
Or should
exhausting
we end
session?
it here?
Ma'am, it depends on the
Archana ma'am?
panelist. If Archana ma'am has
Can we
left,
take 10
ma'am.
minutes?
I
Okay,
think
This
we'll
ma'am.
is
do it
one,
like
this
a
last
rapid
case.
fire.
Rapid fire,
Go
quick,
ahead,
quick.
yes.
Yeah.
Rapid fire
Last
we
case.
will do. I think it's all 7:10. Yeah. So we had a 25-year-old hypothyroid on thyroid supplement, married for 4 years, non-consanguineous marriage. She had 3 abortions, all first trimester abortions between 6 and 8 weeks. In the first pregnancy, no scan done. Second pregnancy, blighted ovum was diagnosed, and endocrine evaluations post the treatment for hypothyroid was all normal. AMH 2.8, no other comorbidities. Evaluation for APLA, ANA, antiphospholipid, ATPOs, torch, everything was negative. Karyotyping was all negative, all normal, in fact. So, husband's 38, obese, non alcoholic, non smoker, high stress level at work, and no other comorbidities. Newly detected HbA1c 6.6, normal semenogram with pus. Semen culture didn't pick up anything, any growth. DFI was 78. Endocrine evaluation for him was normal. Ultrasound showed bilateral grade 2 varicocele. Quickly, next line of management. And do you want to do DFI? What do you think, if it's high, varicocele repair, how many if you want to do? And what else? I think one
So,
answer from each one of you.
Currently, andrologists don't
Hmm.
recommend varicosilectomy. They ask to put
We'll
on
start with
antioxidants
the
and use.
lifestyle interventions first. Let us first
Correct.
consider lifestyle interventions. High pressed
Lifestyle.
dog, yeah, he has to now be told weight loss, sugar control, and then some meditation and stress management. He has to be
Exercise.
told. Then we can go on to the pharmacological treatment. What Madam has started talking about the management of DFI now. So step by step we can go all the things we have to counsel the couple together. So that may be leading to the problem. So as far as varicocele repair is concerned, because there are specific indications, if DFI is high, maybe some may consider it doing, but there are specific indication of undergoing varicocelectomy and discuss.
Varicose be operated. Also,
Antioxidants have a role to play besides lifestyle modification, diet, exercise. Antioxidants should be given to a male with raised DFI
ma'am,
and
frequent
advanced.
ejaculation also helps in patients with high DFI. Majority of our patients, we tell frequent ejaculation every 3 to 4 days once. We have seen much improvement. We have done a thesis also. A fellow of ours has done a thesis also, and we have got significant improvement in the DFI.
So do you do TFI for all patients? Or
No.
is there any specific indications?
No.
RIF,
DFI, we would not do it for all patients. This would be only done like in this particular kind of case, that it would be done that if we are getting this kind of a problem. So otherwise it is not to be done for each and every couple or every person who is coming. So in case we are thinking that there is a recurrent pregnancy loss and or a recurrent implantation failure, then definitely we would like to know what is the sperm DNA. And sometimes the report of the sperm, the semen analysis might be quite normal, but when you do the DFI, then you find that it is abnormal. So definitely it would be useful in this kind of case of recurrent pregnancy loss, implantation failure, unexplained infertility, repeated IVF or ICSI failure, and yes, as you mentioned, if there is a varicocele, then also a DFI would be required.
Couples who are having day 3 embryo arrest, 40 years, more than 40
Yes.
years, obese, history of smoking, severe odds. In such cases, maybe we can do a DFI.
Yeah.
Yes.
Perfect. I think this is what the guidelines also say, only when it is palpable varicocele, RPL, RIF, all those are the guidelines where DFI is recommended. Otherwise, on a routine, not recommended at all.
Antibiotics will
And
help in this particular case.
Madam,
yeah,
I
because
want
he did have a little pustles as well.
Yeah.
Madam, I want to add on something because this is the recent which I observed, that when the patient comes, especially the techies, the softwares, when they come with that erection disorders, like they have early ejaculation and early erection. I mean, when we do the semen analysis, yes, there will be an issue with the motility and morphology. But in some cases, I did a routine DFI actually, and trust me, all the people who had early ejaculation and early erection all had a DFI issues, and which was picked up actually. It was showing all about 25%, 30%. So I think so we need to see that point also, because the patient history also matters a lot, because there are many times male patients, they think twice to tell to us whether they have some erection or ejaculation problem. I think so the proper history of them is very much important. And even sometimes there are people where they've been smoking and they have stopped from past 3 years or 4 years, they have quit completely. Even those people, we have seen that the DFI is increased. I think so this also to be seen regularly. I don't know how many people will agree with this.
See, if there has been an ICSI failure in the previous cycle, would you like to go for a testicular sperm aspiration and use that TESE or testicular sperms?
You can use microfluidics or such as
Yeah,
advanced
okay.
sperm selection
Microfluids
techniques.
is one
option.
Microfluidics, testicular sperm, all are
Yeah.
something, evidence based.
So I think testicular sperm can be used in the subsequent if you have had an ICSI failure. You don't want to have another ICSI failure, that is not this thing. So it can be offered to the couple, and if they agree, because testicular sperm practically will not be having this. There is a lower incidence of this high DFI in there because you collect it directly as it's produced. So I think these are the take-home
Is
messages.
somebody using Max, ma'am? Anuradha? Max.
I don't
Health.
use.
We
Anybody
don't
else,
use, but
Max?
again, improve it. This is not
I
something
don't use. I don't
recommended.
use
Yeah,
Max
we
and
don't
Pixie.
use it.
Madam,
I
I have
don't.
one more doubt. People with high DFI and what Anuradha madam said that we'll do TISA and we will go ahead. Do you think for such patients also we need to counsel PGT? Do you recommend?
Obviously, ma'am, blighted ovum so many times.
Yeah.
Advanced paternal age is also associated with aneuploidies. If a male is more than 40 years, so
No,
that
I'm
also
telling.
severe oats is
No,
also an indication for PGT. So maybe
not for
that.
this, not for this, not for this. I'm talking in general. Like suppose the patient is somewhere around 35 or 30 years or 36 years, less than 40 I'm talking about. And do you recommend for all patients with high DFI?
Not
And
all. I
No,
would
not
not
necessary.
no,
Not
not necessary.
necessary.
One is age is important. Second, if you have had a recurrent implantation failure or recurrent pregnancy loss, and mind you, earlier little definitions have been changed recently. Now they
Yeah.
say कि if you have 2 pregnancy losses, you start doing this PGT and go on the lines of recurrent. Earlier it was 3 abortions. Now it is at 2 only. But nowadays, people are having just 1 or 2 children, and nowadays, you give them a proper counseling if they want to go for a PGTA. You don't they nowadays, we are in that IT city. People read about
But
everything.
what if the
Yeah.
patient has never conceived, madam, never conceived, and the DFI is very high, and her the husband DFI is very high, and
Aishwarya, I
all
think
these
it's all
things.
about counseling, how you counsel your patient. And please remember, PGT again comes at an extra cost. I
Yeah,
think it's
yeah.
with the consent. See, so it's like just like pregnancy, so many times we do have patients, even 38, 39. When you say amnio is 100%, your NIPT advanced testing is 98, 99%, they still say, I want to, irrespective of no history in the past. So it's all about counseling, and it's the right of the patient to choose what they think is right. Counseling, I think, plays a very important role. Yes, you can definitely offer, especially because I think, like Dr. Anu mentioned, you're planning one, maximum is two, I would say majority one. So yes, options can be given to them if they choose, but it's like a menu card method where you tell them
Okay.
things are
But I
available.
think what
Okay,
Dr.
madam.
Aishwarya
I think
will
we have to treat this patient also for the antibiotics, for antioxidants, and you can repeat this DFI after, if patient is young, they are not in hurry, you can repeat it and see whether there has been any improvement. But in today's era of IVF technology, automation and all these big things, ICSI failure is not taken well by our patient. So I would go all out and try and prevent that next time in my lab there is no ICSI failure. I think everyone will agree to it.
Yes, I totally agree. I think it's also important, counseling the patient on lifestyle modification, stop alcohol, smoking, weight optimization, genital infections, like you mentioned, infection, antioxidants, short abstinence. Somebody mentioned short abstinence works very well. Repeat the DFI works well, perfect. Microfluidics, if you have the availability, please do it. Otherwise, Max and Pixies are all something that you can think. And testicular sperms also will be better. And for this patient, microfluidic sperm sorter was used. ICSI was done. 11 M2s. Day 5 blast was obtained. One A44 blast was transferred. She conceived and she's right now 20 weeks. Anu, do you want to take the rapid
And
fire for the last one, or
no,
we'll
we
close
meant
it?
because I think it was still 7, right? If I'm not mistaken.
Yeah, yeah.
I think we have overshot.
I must congratulate. It was very nice discussion on DFI.
I'll stop sharing. Yeah. Okay.
So thank you
Before that,
everyone.
before we
Thank
end,
you all the
Just one
wonderful
thing.
panelists and
thank you.
Dr.
Anybody
Lavanya.
would like to do normal IVF rather than ICSI failure is there?
No,
ICSI
IVF works
failure.
on natural selection, ma'am. So,
Naturals, yes.
yeah.
So I think the take home is thorough history. Decide, where is the problem first you identify and sort out the problem, be it the male or the female factor, and correcting is something very, very important. I think all of you were wonderful, really great interactions. And I would also not like to miss on thanking our coordinators, Dr. Rudri Agarwal and our beautiful MOC, Dr. Komal. Thank you. And thank you all. Thank you for this great
Yeah, it was
initiative,
Thank you so
Archana
much,
really
ma'am.
very,
ma'am.
very
It was
good
a
Really,
panel.
great panel.
Yeah,
Thank you so
great.
much,
Yes.
madam. It was very
Thank you,
nice.
Dr. Parul,
Seema
Dr.
ma'am,
Sima,
really
Dr.
great.
Deepika,
Yeah,
Yukti,
Dr.
everyone.
Anuradha
Dr.
and
Lavanya,
Dr.
thank you.
Lavanya, your panel like included every
Thank you.
aspect and
Thank you, ma'am.
very, very interesting and a lot of interaction in between. It was
It
really
was
good.
good for
We had
general
great
OBGYNs
panelists.
also.
Yes,
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 yes.
that's
Yes.
for
We
Dr.
good
wanted
for
to
Monica,
good
cover
thank you
and
for
so
the
include
much.
general.
everybody.
Yes,
And let's
because
thank our sponsors, FarmEd, and also our hosts for the day, MP ISAR Chairperson Dr. Archana Baser, and our sweet secretary of MP ISAR, Dr. Brijwala. Thank you so much for the invite, and thank you taking out time from your
Yeah.
busy
Thank you so
schedule.
much.
See you
Thank you,
again.
Thank you.
everyone.
Thank
Thank
you
you.
all.
Thank you,
Here,
everybody, very much.
here I
Thank
would
you.
like
And
to invite on
good
behalf
night
of
to
my
everyone.
chairperson ISAR and myself, because she's going to be the organizing chairperson for ISAR 2027 at our Bangalore. Please, we welcome you to our city. I'll be the organizing secretary for the conference. We invite you all with an open heart. Please come to our city, allow us to host you, and I'm sure
Nice.
you'll not forget this
Yeah,
ISAR
Dr. Anuradha, please
2027.
share the brochure. Please share
Yes,
the
it's
brochure in
4,
the group.
5, 6,
Thank
7
you.
I'm
February
putting that.
2027.
Yes.
Bye-bye.
Thank
Thank
you.
you so much,
Congratulations
ma'am. Thank you so much,
and
everyone.
Good
congrats
night.
and
Thank
Thank
you
you.
very much.
Thank
Good
you.
night.
Thank you, everybody.
Thank you so
Really
much.
enjoyed interaction, and I'm really glad that there was. I am going home enriched with such an interesting panel. So thank
Yeah.
you very much, all of you, to have
Yeah.
joined.
Ma'am,
Thanks.
I
thank you,
also
Thank you,
want to
Sudeep ji,
take the
for a
privilege of.
platform.
Yeah. Sudeep ji, thank you so
Thank you,
much.
Archana. Thank you, Archana, for
Thank you.
making
Thank you
this
all. Please
like
block your dates as well.
webinar. And
And
Birwala
thank
and Dr.
you,
Seema
Komal.
Prakash.
Yeah,
Thank you
thank
so
you
much,
so
ma'am.
much.
Congratulations.
I would like to give
Thank you.
one vote appeal for our host, Dr. Archana Baser.
Very
Yeah,
much.
All the best.
sure.
Dr.
Definitely.
Yes, ma'am.
Archana, all the best for your Foxy election.
Yeah,
And
Dr.
Thank you.
Archana.
Thank you.
yeah,
Thank you, Dr. Anuradha. Thank you
yeah.
so
Yeah.
much.
And
All
Look
yes,
forward
everyone
for
will remember
every
you
vote and vote.
as that ever interested in academics and always dynamic. And all the best from all of us here.
Thank
Yes.
you.
And
All
Dr.
the best,
Archana, we are
ma'am.
with
And we
you.
will
We are
definitely
with you.
vouch for you for your election.
Thank you.
best of
Thank
luck,
you
ma'am.
so much.
Thank you so much, everyone, for
Yeah.
All the
joining
best, Dr.
today.
Archana.
And
Yeah. Thank you. Thank
I would
you.
like to say thank you to Baser ma'am as well for sharing her valuable knowledge. And definitely, we are here for to support you, ma'am, and to cheer you, ma'am, as your vision, your commitment to our fraternity and
Thank
your
you,
guidance.
Komal.
It brought us here today. Thank you so much, ma'am, for you because of you, Karnataka, MP, and Delhi all are here on the same platform. Thank you so much, ma'am.
Yeah.
Thank you.
Thank you and good night,
Thank you.
everyone.
Thank you, Seema. Thank you, Komal. Thank you, everyone.
Thank
Bye
you.
Thank you,
bye.
ma'am. All the best. We are with you.
Okay.
good night. Dr.
Thank
Lavanya
Good
is
night.
left.
Bye-bye. Yes, I'm here. I'm here.
Yeah.
Yeah.
One more
Thank you,
time,
Dr.
remind them
Lavanya.
about our ISAR.
It was a wonderful panel discussion
Yes.
for us, the core OBGYNs that we send our patients
Please
to
display
you
that
for
ISAR
IVF.
ka slide if you have.
We
Done,
learned a
done.
lot.
It's
on the display.
Yeah.
Yeah, we
And
learned a lot.
thank you, all the faculty members, because of your presence. It was possible for, it was such a great evening to join this panel discussion today. Thank you so much, Lavanya ma'am, Anita ma'am,
Thank
Anuradha
you.
ma'am, and Seema ma'am, Deepika ma'am, Yukti ma'am. Thank you so much,
Thank
Thank you
you.
so much, Komal.
Bye.
Bye
Good
bye.
night.
Bye,
Bye.
ma'am.
Bye.
Good
Good
night, ma'am.
night. And all the best, ma'am.
Thank you. Thank you so much.
Thank you, Dr. Seema. for having us all. This is the
You're
first.
most welcome. We'll continue
Yeah,
with
this is the
this.
first for and we go on
This is
from here.
really a great idea.
Yeah,
Really
अच्छी
great.
सी
we'll
शुरुआत हो गई
continue.
every
Dr. Lavanya and Komal
Yes.
will try to
Yeah,
continue
Definitely,
this.
ma'am. Definitely. Yes, ma'am. Thank
Yeah,
you so much, ma'am.
yeah.
Take care. Bye-bye.
Good
Bye.
night. Bye.
Bye.